Good evening, Dr. Puneet.
Good evening, Dr. Ritu. Good evening, everyone.
Good evening,
Uh,
everyone.
and I think it's 6:15. Thank you so much for joining. I have because I think we're planning to stick to time.
Hi, Dr. Kokila. कैसे हो?
Hello, all good, ma'am. How are
All
you?
good. I'm good. I saw your name. मैंने कहा कोकिला से फिर कनेक्ट हो जाते हैं.
So आपका इंट्रोडक्शन मैं ही दे रही हूँ मैडम.
You can call me Ritu. I know you so well.
Oh.
Hi, it's already 6:15 and you can start with the welcome address. Lot of joined.
Thank
Yes,
you.
ma'am.
Thank you.
Good
Abha
evening,
ma'am.
ma'am. Good evening, ma'am.
Good evening. कैसी हो रितु?
Ma'am, good.
Okay.
Thank you. Thank you. So,
Yeah.
starting this webinar, welcome to everyone who has joined this evening. At the outset, I would like to thank IFS for giving us the platform. Thank you to our mentor, Dr. Abha Majumdar ma'am, for always guiding us. Thank you to the faculty who has been very kind to give their time and share their knowledge with all of us. And thank you to kids also who have joined us in good numbers. So I would request to begin with Dr. Abha ma'am, our mentor, SIG Reproductive Endocrinology, to give us few words of wisdom and give to webinar.
Hi, good evening, everyone. Good evening, Puneet. You are taking a lot of pains for your special interest group, and I'm very happy to see you in it. It's a very important subject, and I think we will have outlined lectures on each of the reproductive endocrinology subjects, which will also maybe include some on, is there also in it?
Yes, ma'am. We will be covering menopause eventually as well.
Yeah,
Thank
so
you.
all reproductive endocrinology, starting from adolescence to menopause, we would have lectures on them, and I'm sure you all will enjoy the whole across you all will enjoy all year across with lectures which are going to help us in our clinical practice. Welcome everybody to this. This is a debut digital conference by the SIG Group Reproductive Endocrinology.
Thank you. Just one kind of a housekeeping point, I would say, please keep your mics at mute because it will be very good to hear and learn when it's in silence. If you have to ask questions or anything, you're more than welcome to unmute yourself or ask one of us to unmute you. Plus, otherwise, please keep your mics at mute. So I would now request, I am very thankful to my co-conveners, Dr. Rajapriya and Dr. Kokila, who have joined me. I would request Dr. Kokila to introduce the chairpersons of our first session.
Good evening, everyone. The chairperson for our first session is Dr. Ritu Jain and Dr. Rita Mahe. Dr. Ritu Jain is a director of Vardhaman Medical, and she has with experience of 30 years in endoscopy, IVF, and infertility. She is a founder secretary of IFS Haryana chapter. She is a national joint treasurer of National IFS, past president of Gurgaon Obstetric and Gynec Society, joint clinical secretary Haryana Obstetric and Gynec Society. She has been a mentor for my center in 2014, and I'm really thankful to her for her mentoring me for IVF. She did training in endoscopy from France, ICOG, IVF, ART training from Cleveland, USA, and Donald Diploma in USG. Contributed in many chapters in the books of IVF Made Easy, PCO in Adolescence, Management of Hyperhomocystinemia in Pregnancy, ECAB Clinical Update 2012, Management Strategy in Recurrent IVF Failure and Safety and Risk in IVF. She delivered many talks and presentation in local, state, and national level conference. I invite her for this webinar. Dr. Rita Mahe, she is a professor of Department of Obstetric and Gynec in AIIMS, New Delhi. She's interested in infertility, endoscopy, ART, and PCOS. She has received Young Gynecological Award in 2017 AOFOG and Dr. Mangla Telanga Best Research Paper Award in Fertivision 2017, Best Research Paper Award in Fertivision 2023 also. I invite both the chairperson to start our session. Dr. Ritu Jain, it's over to you.
I think Dr. Ritu has a problem. Dr. Rita, can you start this
Yes,
session?
ma'am. Yes, ma'am. Good evening. Good evening, Dr. Puneet. Thanks for involving us for this session. And so, may I take privilege to invite Dr. Ava Majumdar. And ma'am is well known among all the clinicians of reproductive medicine. She has got so many awards, including she had the credit of first baby of North India. And in addition to a lot of international and national contributions, she has got life achievement award by Indian Fertility Society also, and she is course for fellowship in reproductive medicine since 2007. So, ma'am will be starting the very important and hot topic of today's scenarios, AMH and its role in fertility. So, ma'am.
Thank you, Dr. Rita. Actually, I had put myself on mute and I was talking.
Oh, no issues. I think let us invite Professor Avam to start the talk. So, role of AMH as a predictor for fertility.
Thank you, Dr. Mahe, and thank you, Ritu. Even if you did not talk, I could hear you. So thank you for inviting me over for this lecture.
Thank
And
you, ma'am.
I'm very glad we have this lecture because these days there is a panic button amongst the youngsters, especially girls who are making a career for themselves with just one AMH and they're trying for IVF, whether they've tried for pregnancy or not. So let us see, is AMH a predictor of fertility and menopause? So when I put this question to you, I would bring another question to you here. I hope it works. Does AMH level alone predict fertility? This is for all the audience. And I want at the end of this slide, please click a picture and answer this. Answer the questions I put over here. Now, there is a situation where the woman comes with an AMH of 0.4 nanogram per ml, but her basal FSH, which means day 2 or 3 FSH, and estradiol are 18 and 80 respectively. Another patient comes whose basal FSH is 13 with E280 picograms, and a third one with FSH of 10 and E280. Who is the best out of these in terms of reproductive outcome? Then comes another patient where AMH is again 0.4 nanograms and the menstrual cycles are 26 to 28 days. Another girl with menstrual cycles shortened to 23 to 25 days. And the third one with menstrual cycles lower, 35 to 25 days. Can we have the delegates muted, please? And yet there is a situation, AMH 4 nanogram, but the age of woman is 31, another girl age is 36, and another one age 41. So who would have the best fertility? In the first group, this one. Second group, the one who has the most normal regular cycles. Number 2 would be shorter and the last would be longer. And the third group, age 31, would have the best fertility. So AMH alone is not a predictor of fertility. We have to look at other factors. We have to look at other factors also, where we can say that with this AMH, this woman will fare better as far as fertility is concerned. So now I bring you evidence, and this is the first evidence I'm bringing you. Is AMH a predictor of fertility? And this is from 2012, where they said that low concentration of circulating anti-Mullerian hormone is not predictive of reduced fecundability in young, healthy women, a prospective cohort study. And this, the conclusion of this study was low AMH in healthy women in their mid-20s did not predict reduced fecundability, even after exclusion of women with irregular cycles. The probability of conceiving was reduced in women with high AMH. So very high AMH, even if you remove those who have delayed cycles. Regular cycles, very high AMH takes more time to conceive rather than low. And here you see from the same study, I brought in two graphs. And the black line indicates medium AMH, the yellow low AMH. On the horizontal line is time to pregnancy, and the other one is cumulative proportion of women achieving pregnancy. And you see both black and yellow line, which is medium and low AMH, have achieved pregnancy in much lesser time, say within 6 months. Whereas the high AMH, which is the red line, takes more time to achieve. The higher it is, more is the time. And less is where it achieves pregnancy. The same is on this scatter plate also, where the red lines again show AMH in picomoles. The higher it is, it takes less of pregnancies, and the lower it is like equal number of pregnancies. I come to another study, which is so recent, of 2022 now. From 2012, I've moved to 2022. And what does this say? So over 10 years also, the prediction is that anti-Mullerian hormone has limited ability to predict fecundability in Chinese women. And this is a preconception cohort study. What was the conclusion of this study? Serum AMH levels were not associated with fecundability in Chinese women of childbearing age. A suggestive association, however, was observed among women with cycle irregularity. Only if cycles became very irregular, then possibly low levels were associated with lower fertility. Regular monitoring of AMH in fecundity prediction may be of limited value among healthy, reproductive, aged Chinese women. Having said that, I now come to the second point, the effective time to pregnancy, which is a very important point when I take histories. What was the time to pregnancy for each of the pregnancies you've had or all the miscarriages you've had? When did you think you want to conceive? And then how many months or years did it take you to achieve pregnancy? We found that there is a decline of AMH concentration as age increases, but there is no relationship between AMH and effective time to pregnancy. In conclusion, our study results suggest AMH concentrations do not influence the time necessary to conceive a live-born child spontaneously, and therefore speak against determining AMH in women who are not infertile for the purpose of predicting their chances of pregnancy. A woman who has never tried, how does she know? How do you know that she's infertile? If a woman comes for preconception counseling, her cycles are regular, everything is normal, then do not predict her chances of becoming as low if her AMH is low. If she says that they're having regular sexual intercourse, cycles are regular, and she's young, 35, 36-year, 32-year-old, even if the AMH is 0.5 milligram, chances of fertility or becoming pregnant are normal. It doesn't affect her time to pregnancy. Their findings were concordant with previous reports describing AMH as a quantitative but not qualitative marker of ovarian function. So it will tell you quantity. Yes, quantity of eggs have decreased, but one ovulation will happen till the end of AMH also, till the end of the reproductive span of the woman. And one ovulation is good enough to make a woman pregnant. And if she is young, even the egg quality has to be good. So it is a quantitative marker, but not a qualitative marker. So we cannot say that your time to pregnancy is going to be more because your AMH is low. No, she could get pregnant within 3 months, like a woman with AMH of 1.5 nanogram also. AMH concentration and time to pregnancy, effective time to pregnancy. This is a graph generated from the same study where you see this is effective time to pregnancy in months, 10 months, 20 months, 30 months, and 40 months. And here is the AMH concentration. So as the concentration goes up, the moment she has 7.5, 6, 4.5, more than 3, the time to pregnancy becomes longer and longer, and pregnancies become lesser and lesser. Most of them happen when AMH is very low to up to 3. Most of the pregnancies, and the time to pregnancy is less than 10 months. Very few take 30 months or even 40 months to get pregnant. So we thought, okay, so we've seen active time to pregnancy. We've seen whether it predicts fecundability or not. Let us see whether it predicts oocyte quality, because we know it is a quantitative assessment. But I'm sure it must be having some effect on oocyte quality also with advanced age undergoing IVF ICSI. So study came up which showed that AMH had limited role in predicting in vitro embryo development potential and had no role in predicting the in vivo embryo developmental potential, suggesting that in women with advanced age, AMH should not be used as a marker of oocyte quality. So it is the age which is a marker of oocyte quality, not AMH. So if a woman is 40-year-old and her AMH may be anything, but AMH is not going to detect her quality. Low AMH doesn't mean that this woman will have a low quality of oocyte. Her age will tell us that the quality of oocytes could be low. And similarly, this is another article which came up very recently in 2022, which analyzed the association of AMH with blastocyst euploidy rate.
Kara, can you please check and unmute, mute the mic, please? Thank you. Sorry.
बीच में मेरा iPad है डॉक्टर साहब के पास लेके आओ
oocyte quality, AMH predictive of the rate of euploid blastocyst in IVF PGTA cycles in this retrospective cohort. So, what is so important that this data will help us clinicians counsel patients with low AMH level. Age is clearly related to blastocyst aneuploidy rates, but a low AMH level does not predict the likelihood of increased aneuploidy in human blastocyst and should be considered important when counseling younger patients with low AMH. So please understand, a young patient with low AMH will not have increased aneuploidy rate, will not have increased time to pregnancy, and her fecundity is not going low because of AMH being low. Now we come. So the conclusion is AMH is not a predictor of fertility, nor of effective time to pregnancy, and nor of quality of oocytes in vivo or vitro fertilization. Now we come to the next question: association of AMH to menopause. Anti-Mullerian hormone, follicle stimulating hormone, and antral follicle count. Risk of menopause within 5 years. So in this study,
लाइट ऑन करो बिल्कुल अंधेरा लग रहा है वो होती है ऑन वो लाइट ऑन करना बच्चे
please find out. Why can't you mute everybody, organizers who are looking after the digital platform? Please mute everyone. There is so much of disturbance coming.
देख लो
Anti-Mullerian. So what were we looking at? The probability of menopause in 5 years based on AMH, FSH, and AFC. So look at the highlights, which are so beautiful in this. They evaluated the ability of several measures of ovarian age to predict the onset of menopause among women aged 45 to 49 years. So what they said that if AMH becomes undetectable, 0.01 is considered undetectable AMH.
Jasmine, you just mute your phone. Jasmine, please mute your phone.
So the highlight is if there is undetectable AMH, 60% will become menopause in less than 5 years. If 1/3 with a AFC of less than 1, which means you don't see any antral follicle counts or you see just 1, will become menopause in less than 5 years. And FSH has a non-linear relationship with likelihood of menopause. And we know all our older definitions considered FSH as a very important marker. And if it was over 40, then we said that the patient is going into POF and will go into premature menopause also. So conclusion is ability to predict onset of menopause was improved with any of the 3 menopausal markers in addition to age, which means AMH, AFC, and FSH levels. AMH concentrations were more closely associated with menopause than AFC or AFS or FSH. Now, again, prediction of age at menopause in women with polycystic ovary syndrome. This is again very interesting. A lot of women ask me that since I have higher ovarian reserve, will I become menopausal later? Yes, findings do say that those who have higher levels of AMH, such as PCOS women, their predicted reproductive lifespan could be 2 years longer than the normal ovulatory counterparts. So, role of AMH in prediction of menopause. Why did I bring this article here? This is from Anilian, and this is the most read article today of the frontiers of endocrinology journal. And it says that overall, while ovarian reserve markers, including AMH, are unmistakably related to age at menopause, they are insufficiently precise to inform on an individual's journey of ovarian aging. The use of ovarian reserve markers for long-term predictions could therefore either lead to a false sense of security or unnecessary alarm. So please don't use them too much, because if you want to predict menopause, you could just raise an alarm, oh, my menopause is going to come. And a 35-year-old girl is thinking that her menopause is coming within 5 years because her AMH is so low. Or we would say, oh, your AMH is good, you will not become menopause, but cycles are going longer and longer. So please do not use them as prediction of menopause. So what is AMH a marker for? This is my question. And we'll see. AMH estimation is essential prior to enrollment in IUI and IVF to predict ovarian reserve, to individualize ovarian stimulation. Whenever we are using drugs for ovarian stimulation with the purpose of doing IUI or IVF, we need to know AMH so we can tailor the drug dose. Then we also need to identify PCOS non-ovulatory women to predict whether they will hyperstimulate ovulation induction or not, and therefore tailor our dose. Then it is also as a ovarian marker important in women who are over 35 with unexplained infertility for more than 4 years. So it is very important to do it in women who have come with unexplained infertility, but women who have never tried to get pregnant. And if they come, then AMH doesn't become an important marker for them. AMH is also used for women concerned about delaying childbearing. And AMH levels are important in diagnosis and management of ovarian tumors, such as granulosa cell and virilizing Sertoli Leydig cell tumors, and then again levels after oophorectomy. So here the AMH levels go into thousands, and then after oophorectomy they come down to almost zero. Assessing, and then it is also important today in assessing ovarian tissue loss after surgery or chemotherapy. So whenever a patient is to be taken for either of the two things, ovarian surgery and chemotherapy, it is good to assess AMH before and 3 months after the surgery or chemo. Now, this is anti-Mullerian hormone cutoff values for predicting poor ovarian response to exogenous ovarian stimulation in vitro fertilization. This was my paper only. When Ruma was my fellow, we published this in 2012. And at that time, AMH was a very, very new hormone on the horizon, which we started using. And then we did a study, and we found that AMH fares better than age and FSH in predicting the overall ovarian response and poor response, though it cannot be an absolute predictor of non-responder status. A level of 2 picomoles, which is almost equivalent to 0.15 nanogram, is 0.5 nanograms, is discriminatory for poor response. So we took off a cutoff of 2 picomoles, but the things have changed since then. And I found papers which are of much recent origin, and this is from Norbert Glitcher, who's a name in reproductive endocrinology, under his guidance, this was done, live birth chances in women with extremely low serum anti-Mullerian hormone levels, and see what happens. They've taken women whose AMH is less than 0.1 to less than 0.4 nanogram, still demonstrate live birth potential with IVF, and whether such potential is age dependent, and find. Here, baseline FSH was 15.7 plus minus 11 MIU. So they also took women who had a FSH of almost 26 or FSH lower. 120 women underwent 254 cycles. 20 clinical pregnancies happened, which is 7.9 per start cycle and 15.6 cumulative, because if 128 women underwent 254 cycles, and a woman underwent 2 or maybe more cycles also, and some women must have undergone just 1. 70 women less than 42-year-old had 16 clinical pregnancies, which resulted in 10 deliveries. And 58 patients more than 42 years had 4 clinical pregnancies, resulted in 2 full-term deliveries, 3.4. So we still have a substantial chance, and we don't refuse these women to go through IVF with their own eggs. So we see that women who are less than 42 or up to 42 had higher delivery rate versus that of an age more than 42. So conclusion is, with extremely low serum AMH levels, moderate but reasonable pregnancy and live birth rates are still possible. Extremely low AMH levels do not seem to represent an appropriate marker for withholding fertility treatment such as IVF from these women. And then there's another study which came out, and this is even later, where they said IVF ICSI in low and extremely low AMH levels in different age groups by comparing live birth rate. I take you down to straight away, when we looked at live birth rate in extremely low AMH, which was less than 0.5, and low AMH, which was less than 1 nanogram, we found that 30.4 was the live birth rate with normal AMH, 14.7 with AMH less than 1 nanogram. And there was, if we looked at the age, then the live birth rate was significantly higher in women less than 35 years or 35 to 40 years with normal AMH. But when we looked at live birth rate in the same age groups with low AMH, then it was lower, 18.6 and 13.3, naturally, because they make less of eggs and therefore lesser embryos. So conclusion is no outcome of IVF between patients with low and extremely low AMH levels. Normal AMH levels resulted in higher pregnancy rate compared to low AMH in the same age group. So we have to compare the age group. Age is important in determining prognosis of IVF patients with low levels of AMH. And this is again a chart, a forest plot, where you see the diamond right in the middle. And this is a reducing diagnostic odds ratio. This is increasing diagnostic odds ratio. And so many studies have been included. And you find that with whatever the AMH may be, the live birth rates don't change after ART. If we match age for AMH. Individualization of controlled ovarian stimulation in IVF using ovarian reserve markers from theory to practice. Say that earlier we used FSH for this marker, but now AFC and AMH has come. And if AMH is high, then we always say that we expect a high response. Main objective is to minimize OHSS risk in this woman. So we use antagonist protocol, and FSH stimulation is done with a lesser dose. Expected normal response, we give standard treatment because we have to maximize success rate. When there is poor response, main objective is minimize treatment burden. So antagonist protocol, and give maximal FSH stimulation so that whatever eggs are there, whatever follicles are there, even if they are still not so gonadotropin sensitive, will come up with a higher dose of it. Now, I'm just showing you this last slide where you see ovarian reserve, where we see AMH versus AFC. Now, this is all from early antral stage, the ultrasound can pick up AFC, but AMH is secreted one stage below that with the secondary follicles also. So AMH gives us idea of the deeper follicles which are coming to early antral stage, but ultrasound cannot see follicles unless they develop a antrum in them. So ultrasound will be able to detect here only. So AMH may be considered as deeper and more sensitive probe to define ovarian reserve compared to AFC. So this you have to remember that this is a chart. And another thing is that AMH reports may vary. This is the real value of AMH, but when it comes to us, it could be instead of 1.5 as high as 2 or as low as 1. And what are the factors which change it? One is exposure. Have the patient be exposed to a long term of OC pills or Dynogest or something else, and we've just done an AMH in that, it would come much lower. Similarly, if a patient is deficient in certain things, have taken metformin for a longer time, again, she would be deficient. I have this written here, and I can just read it out to you. What are the things which oral contraceptives, drugs like clomiphene citrate and metformin used in fertility treatment can temporarily decrease AMH levels. On the other hand, supplements like DHEA with vitamin D have been associated with increased AMH only temporarily. And then the last is the laboratory. Now, a very, very interesting thing is that if in the laboratory, the whole blood is kept without processing, then AMH will, the value of AMH would be 31% if it is kept for 4 days. But if we separate serum and keep, it will not change so much. Similarly, room temperature and a temperature at 4 degrees centigrade shows markedly reduced increments. So having said that, I'm coming back to the normal slideshow. Sorry for this. So, your AMH with the laboratory and exposure can change from 1.5 to 2.5 and 0.5. So please look into the circumstances when the AMH was done. Last of all is, at present, due to the low accuracy of ovarian reserve test in pregnancy prediction, exclusion of patients other than based on female age is not to be supported. Low AMH or low FC should not be a criteria to refuse IVF with self-oocytes. So I conclude that variability in AMH stems more from the laboratory rather from a woman's biology. AMH appears most reliable marker presently to diagnose PCOS, POF, and endocrine secreting ovarian tumors, as well as to determine change in ovarian reserve post-surgery and therapy. AMH is possibly better in efficacy to AFC for ovarian reserve prediction. Low AMH concentration is not predictive of lowered fecundability. AMH levels are not related to effective time to pregnancy in natural pregnancies. The use of AMH in ovarian reserve prediction has enabled us to develop individualized controlled ovarian stimulation for IVF to optimize cycle outcome, and not only for IVF, even for IUI. Low AMH has poor association with live birth rate in IVF. It is age which is associated with lower live birth rate in IVF. And low AMH level should not be used to refuse women from IVF with self-oocytes unless they are of high age, higher than 42. Also have a possibility of 3 to 5% of having a live birth with it. So that is all I had to say for today. I thank you all for a patient hearing. And now I give the board in hand of our chairpersons to ask questions if they have any. Have I exceeded the time?
No,
Thank
no,
you, ma'am,
ma'am.
for an elaborative talk, and it is very important for us whenever we are assessing fertility to consider other things also, AFC and all. Ma'am, I had one question. Have you also seen the association of low AMH with more miscarriages or aneuploidies?
No,
And
no.
no, it is
I have
primarily
seen
age
higher age with more aneuploidies and more
related.
miscarriages.
And in young age, it is not that the low AMH is associated with recurrence. Thank you.
Thank you.
Thank you, ma'am, for very elaborative talk. I think so. It's very important for especially for the beginners. So AMH is not the sole criteria to say no or to decide for our fertility treatment.
Thank you.
Yeah, thank you, ma'am.
Hello, Dr. Ritu.
Yes, ma'am.
I want to ask one question. Pramila here.
Yeah.
As madam has already said, ki low AMH who has not tried for fertility is not an indicator. But these days, the girls are postponing their pregnancies and family planning because of their career. So they come and ask what test should be done to predict our ovarian reserve. So any association with day 3 FSH, if AMH is low plus FSH is high, does that predict this thing even?
Yes, ma'am. Whenever they are asking for assessing their fertility,
I think you did not listen to the lecture.
No, I have listened to the
AMH
lecture.
is also used for women concerned about delaying childbearing, and this is for career-seeking women only. When they come to you and say, that, yeah,
If patient is already 35 and her AMH is low, what should be the advice given to that?
the advice should be that preserve your fertility. If you are married, preserve embryos, and if you
Yeah.
are not married, preserve oocytes, and then have your pregnancy whenever you are ready.
He has not tried fertility at all. Should we advise preservation or should we advise them to try first, and if not,
No, if she's not ready to have a child still at 35, you have to consider her priority first. No, she doesn't want a child now, but she wants it 2 years later. Then fertility preservation is the best choice. And if she has a stable partner or she's married, then the best is to preserve embryos for fertility preservation. If she doesn't have a partner, not married, then preserve her oocytes.
okay.
Okay?
Thank you. Thank you.
Mm.
in practice, ma'am, we use all the three antral follicle count, of course, age, AFC and AMH. If someone is 30 to 35 to predict, I think, is that the right approach?
Yes, very right. Don't just use AFC, AMH, and age. Also look at her basal FSH and estradiol ratio. And also look at the cycle length which she has. All this together will tell you that at this AMH, what is her probability that she would be ovulating regularly and she could get pregnant in case she has not tried a pregnancy till now. Tried enough till now.
I just have a question, ma'am. Thank you so much. What is your cutoff for the FSH, ma'am? What you feel like before, like, with AMH, you clearly said that we should not refuse treatment to anyone with low AMH. But is
See,
there a cutoff of FSH you
I
use?
wouldn't go with the FSH. I have taken people with a FSH of 20 also, which I used to use as 14 as a cutoff. But when I see that they have antral follicle counts, when I see the AMH is still 0.4, 0.5, even with the FSH 17, 18, 19, if the estradiol is not higher than 80 or 90 picograms, I try to stimulate and see whether it will help them. And if she stimulates into and she has cycles which are still regular, then she always has a probability of getting stimulated. But gonadotropin may not be a great option here because you have to go above her threshold. So gonadotropin with maybe clomiphene or letrozole together would be a good option here to take her FSH levels above the threshold where she recruits more follicles and has a greater probability of getting pregnant. So look at both the things, FSH, maybe 20, at 20 also, if she's having regular menses, you can always give her a try. Don't refuse.
Ma'am, Nisha here. Good evening, ma'am. Thank you so much for the excellent talk. Ma'am, I
Yes.
just wanted to ask you one thing. Like sometimes I see that when the initial phase FSH is very high on day 2 or day 3, what I do is that I just don't, we see that these follicles are recruited very fast. On 4th or 5th day, we will have a dominant follicle. So if we just let that one go, the FSH comes down, and then in luteal phase, if we stimulate, then we get a very good egg for these patients. So maybe that could be another option.
All right. Maybe what you're saying is right, but the threshold of FSH, what is the basal FSH indicating? It just tells you that now her FSH is going to be at this level and you will have to take it above this level to have a follicle recruited into that cycle as a ovulatory follicle. Ordinarily, when a person has FSH of 5, 6, 7, or 8, that is the basal FSH, and you have to just take it over that. And when you see the FSH levels, we normally don't see FSH levels, but if you see it on day 5 of your stimulation, you will find it's gone higher because that is when lots of follicles are recruiting over there. So what you're saying in luteal phase, this is what happens in every cycle, that
Yes,
unless the FSH threshold is not crossed, a recruitment will not happen. So even if the FSH is high, another cycle it could be slightly lower. FSH is variable from cycle to cycle, but not
Yes.
very variable. And we normally say the highest level is the truest level
Yes, ma'am.
for that thing.
Yes, ma'am. Thank you, ma'am.
Thank you. Thank you so much.
Thank you, ma'am.
Over to Dr. Puneet.
Dr. Ritu, shall we wind up this session?
Yes, ma'am. Yes.
Okay. Thank you, Dr. Ritu, Dr. Rita, for being an excellent chairperson. Dr. Kokila, I'll hand over the mic to you again.
1 second. Can I
Dr. Ra-
leave? I have another meeting after 7. Can I please leave?
Yeah, thank you,
Thank you,
ma'am.
ma'am.
Thank
Thank
you
you.
so much,
Welcome.
ma'am, for being a part of this. Thank you.
Thank you, ma'am.
Thank you so much.
Dr. Rajapriya,
Yes, yes.
yeah, you just start the inviting of the chairperson.
We will now move over to the next session. I invite the two chairpersons, Dr. Neeru Thakral and Dr. Nymphia Valecha. Dr. Neeru Thakral, she is the director of the Thakral Hospital at Gurugram. Can I have her CV, please? And she holds quite a lot of busy position in IFS. She is the national advisor of Indian Fertility Society. She is the national coordinator of the IFS Young Turks Journal Club. She is the secretary general of the Gurgaon OG Society. And she has to her credit a fellowship in reproductive endocrinology, and she holds an apt place today as a chairperson in this particular SIG endocrinology program. I also invite Dr. Nymphia Valecha, the other chairperson. She's an infertility and robotic consultant at Fortis, Shalimar, Delhi. She's also an important person from the research-oriented side. She's a joint editor at IFS, and she's a web editor and joint secretary at Fertility Preservation Society of India. She's a forum coordinator of the Delhi Gynecologist Forum. So I'll be very happy that both the chairpersons take over this session and introduce Dr. Puneet. Thank you.
Thank you, Dr. Rajapriya. So now it's my great pleasure to invite Dr. Puneet Rana Arora. We all know she is the convener of this SIG Reproductive Endocrinology. She's a chairperson, I think. Hello. Yeah. So Dr. Puneet is the founder and director, Sifar Gurgaon. She's executive member of Indian Fertility Society, founder member of Fertility Preservation Society, medical advisor Cancer Survivor Project, CanKids, advisor for Late Effects Committee of Indian Cancer Society, executive member and fertility advisor for TICAN India. She is recipient of Bharat Gaurav Award for Excellence in the Field of Reproductive Medicine, Asia Pacific Excellence Award, section edited for Fertility Science and Research Journal, peer review for Fertility Science Research Journal. Publication, she has many publications in her record. Area of interest is recurrent implantation failure and fertility preservation. So moreover, she is a good friend and great human being. Welcome, Dr. Puneet. All yours.
Thank you. Thank you very much for your kind words, Dr. Neeru. It's been a pleasure being here and speaking on subclinical hypothyroidism and thyroid antibodies, implications in our infertility practice. And I think this is a topic which I feel that it's very controversial still. Even if I speak it, I'm sure there will still be a lot of questions, because there are certain scenarios in medicine which I think the research keeps on going on. And I hope one day we become more clear with what we need to do. But let's hope I justify this topic and give some take-home messages as to what we should do. So we all know that thyroid hormone is involved in reproduction in some way, is closely related. Reproduction does depend upon normal thyroid hormone levels. It has direct effect on the ovaries, sex hormone binding globulin proteins, and its disorders may negatively affect the reproductive functions. We also know that dysfunction in thyroid, either hypo or hyper, can lead to menstrual dysfunctions and infertility and recurrent miscarriages. So what can be the cause of thyroid dysfunction? Just a brief overview: autoimmune thyroid diseases or Hashimoto's, iodine deficiency, which in India at one point was very common, or it can be iatrogenic following radioiodine therapy for surgery or for cancer treatments. The cancer treatment is on rise. So we are seeing a lot of patients with iatrogenic hypothyroidism. And the question to us as fertility practitioners is, has it got any relation to pregnancy and infertility? Which I think what we will be discussing. So when we talk about thyroid dysfunction, we know there are two broad. One is the overt hypothyroidism and the subclinical hypothyroidism. Talk about overt hypothyroidism, it's very clear. And I think there is no confusion. The TSH level is increased and the free thyroxine levels are low. It can be associated with symptoms. We know that it can lead to problems in pregnancy. It can lead to of pregnancy with preterm labor, preeclampsia, miscarriages. It is a subclinical hypothyroidism, which is a dilemma. It is a milder form of hypothyroidism. It does not need treatment as such. So there's a controversy in its management. Whether it's involved in infertility and miscarriages is a controversy. So what is subclinical hypothyroidism? It's an early form of underactive thyroid problem. It is a of serum TH. The exploratory stage, company normal hormones with T3 level. It's automatic and it represents the stage of function. See, there are controversy. What should clinical hypothyroidism in it, whether it is not non-pregnant. I think we all learn that in semester cutoff 2.5, it is more 0.5 as hypothyroid. For second, the cutoff and semester, it is in the non-pregnancy still what is a, because studies this there is an miscarriage and far in kind of the conclusions which I will discuss in the later part of the slides, that the TSH value of 4 to 4.5 milli-IU per liter is something which is taken as a cutoff to define the subclinical hypothyroidism if a woman is not pregnant and seeking pregnancy. But we always have that figure of 2.5. Where does it come from? Because initially it was thought that 2.5, because then I'll discuss that there is a criteria that around 95% of the values of thyroid, if we do in a population, are less than 2.5. So 2.5 to 4 is a gray zone. We know that more than 4, 4.5 is what we called as more or less overt hypothyroidism. So this is again what we need to decide and treat rightly. So what are the controversies? The claim is that some believe that it is just a compensated hypothyroidism. It is not a disease or any abnormality. The reason being that TSH stimulates the thyroid gland to produce normal hormone levels, implying the individual is euthyroid. But we also know that the half-life of T4 is 7 days, T3 is 1 day, and TSH is less than 1 hour. So if thyroid hormones levels were truly normal, TSH would return to normal. But persistent elevation on 2 occasions of measurement of TSH gave us enough evidence that there is something going on to compensate the low thyroid levels. So the clinical implications are, yes, the TSH is elevated. It leads to subclinical hypothyroidism and should be treated. So finally, we conclude that yes, it is not a myth. Subclinical hypothyroidism is not merely a compensated hypothyroidism, but it's a clinical entity and does need attention and treatment. So what is the incident? So it all depends on what lab ranges we are using. Like I said, there is a debate whether we use 2.5, whether we use 4.5. There are studies in all of these subgroups. If we look at the cutoff of 4.5 and 5, the incidence is 4 to 8%. But we also know that 95% of individuals without evidence have a TSH value less than 2.5. So if we take the cutoff as 2.5, the incidence rises to 11.8 to 14%. So it all depends what population. If you look at the Indian data, this is a study in 2013, which showed that the hypothyroidism is present in 13.5% of cases. The next study, which came in 2020, showed a rising trend to 24% of hypothyroidism subclinical. And the most recent study has shown an incidence of around 33%. So it is rising. Is it genuinely rising, or are we more aware about it? Are we more doing this test in our practice? So that's something we need to know. And also, this was an interesting study which looked at the infertility. Which looked at the infertility population, and it showed that the higher incidence of subclinical hypothyroidism was more in the group of unexplained infertility and in patients with endometriosis. Why endometriosis? Because there is a risk, there's a reason that endometriosis can be associated with autoimmune thyroiditis as well. But if we look at the international data, it has shown, the US study has given us the estimation of 2.3% of elevated TSH with normal T4 levels. Finnish study, the incidence for 4%. In Argentinian study, 14%. So we can see the variation because we still don't know what is the cut. But what we are concerned is it associated with infertility? There are a couple of good studies which have shown that there has been no association of subclinical hypothyroidism with infertility. And another study in which it was done in the patients undergoing intrauterine insemination, IUIs, with a level between 2.5 to 4.5. In comparison to the less than 2.5, they found no difference in
Just a second. Dr. Puneet, give me 1 second. Can I please request the organizers to mute everyone? Please.
So these two studies have not shown any infertility association, neither any difference in the pregnancy or the live births. There's another study, retrospective, which included 244 women and compared the prevalence of subclinical hypothyroidism in these two groups. And it was found that, yes, subclinical hypothyroidism was present in 14% of patients with infertility versus 4% in the control group. So it did mention that, yeah, whether it's a cause or the effect, it's not known. But there was some association of subclinical hypothyroidism with infertility. And this is a study from 2007. When we do our IVF procedures, we are also keen to find that would high TSH, which means between 2.5 to 4 or more than 4, with our IVF outcomes. So this is a study which was published in 2003 with 509 specimens. They did found that high TSH concentrations was shown to be a predictor of fertilization failure in women undergoing IVF, which does plays kind of supports the role of thyroid in oocyte physiology. TSH concentrations were reported to be higher among women who produced oocytes that failed to fertilize. Among women who had at least one oocyte inseminated, the likelihood of having less than 50% of their eggs fertilized was independently related to higher TSH concentrations. So it did conclude that high TSH concentrations may predict poor fertilization. But having said that, these all studies are retrospective, not powered, but do give information as ponder on and maybe do our own analysis, audits, and research for finding our own data. So one aspect is infertility. But obviously, as an infertility specialist and as an endocrinology specialist, not planning to be pregnant. So we have to make sure we have pregnancy. Does that alter thyroid status dysfunction? Affects this pregnancy when they get pregnant. So that is also one important parameter we have to keep in mind when we see such patients. So this was a study from it was basically a review which took into consideration 16 observational studies. And what they found was that the TSH in the range of 4.29 and 10 was associated with adverse pregnancy outcomes, including abortions and preterm birth. So I think that initial value as 4.5, I think more or less that's clear that that needs treatment. But again, we have a little query on whether between 2.5 and whether those values of TSH, do they have adverse outcomes on the pregnancy or not? That's still a question. So again, we know that why it is important to maintain adequate thyroid levels, because we know that the baby doesn't start producing its own thyroid hormones till the 3rd trimester. So it's utilizing and the initial development of the baby is needed. The thyroid is needed for the initial developmental phase. And hence that's important to maintain the levels of it adequately. And if the patient is getting pregnant by infertility specialist, it's important that those levels are maintained. So proper management of TSH levels is essential to prevent complications like preterm birth, preeclampsia, miscarriage, and developmental issues in the fetus. So hence, we as fertility specialists do become little kind of concerned about optimizing the thyroid levels when they come for the treatment. And hence, as a part of our routine investigations, we do include free T4, T3, and TSH as markers to assess them. What about antithyroid antibodies? So antithyroid antibodies, as the name indicates, they are targeting thyroid proteins. They indicate that it is an autoimmune thyroid disease. The incidence is 10 to 20%. It's seen more commonly in women with increasing age. And we all have noticed that in our OPDs, the women who come and seek treatment, the age is advancing. So I think the time has come where maybe we should screen our patients for antithyroid, but it's a bold statement. We should not do it till we kind of have more robust evidence. So and autoimmune thyroid disease describes the presence of circulating antibodies that target thyroid glands. There are mainly 3 antibodies: thyroid peroxidase, thyroglobulin antibodies, and receptor antibodies. From point of view of subclinical hypothyroidism, thyroid peroxidase antibodies are the most sensitive marker for the detection of thyroid autoimmunity. They can be associated with Hashimoto's thyroiditis, Graves' disease, and other symptoms. So what exactly they predict? They can help us to predict pregnancy complications, fertility issues, maternal and fetal. Let's just see some of the studies which kind of come and indicate more on whether they should be given that much importance when we screen our patients for normal thyroid profile. So the evidence indicates that yes, they could be associated with infertility. Their incidence was found higher in women who approached for infertility treatment, and especially women who were carrying endometriosis or who had an ovulatory dysfunction. So this is a study from 438 infertile, where the prevalence was found to be 18% in women as compared to 8% in the control. Obviously, antithyroid antibodies are not used for the diagnosis of subclinical hypothyroidism, but the question is, if the values of TSH are between 2.5 to 4, should we associate our investigations with these antibodies to find out whether they have a likelihood of converting to overt hypothyroidism? Because that has been shown in some studies as a marker of conversion to overt hypothyroidism. So this is a study which was the prevalence of autoimmunity in women with history of miscarriage or subfertility, in women carrying the thyroid peroxidase antibodies. This was shown that the incidence prevalence was 5 to 20% in women of childbearing age. And the women who had subfertility had an incidence 31% of presence of these antibodies. With the patients of recurrent pregnancy loss, the antibody presence was noted in 17 to 33% as compared to general population of 6 to 20%. So this was a large prevalence study, basically in which the majority of women were from miscarriage and subfertility group. So they did found that also that the BMI was also an associated factor, which was associated with high incidence of thyroid peroxidase antibodies. So whether the kind of adversity in such group was because of the BMI or because of the thyroid antibodies is still, they could not, that was a limitation of this study. So do these antibodies make any difference? That's what the question is. This is a study from 2014, which showed that yes, it could be associated with an apparent increase in the risk of miscarriage across the range of thyroid functions, although rates were not significantly different in women with TSH value of 5.2 to 10. And the values, when were more than 10, they found an associated increase in the risk of miscarriage. So this was another single-blinded randomized controlled trial in women with thyroid peroxidase antibody, which demonstrated a reduction in preterm delivery for women with an initial TSH of more than 4 compared to TSH of less than 4. So, but overall, again, this number of treated women in this study was small. So whether we can conclude that, TSH cutoff of 4 and more and 4 was associated with preterm delivery is again not a definitive conclusive marker. So let's say what the guidelines and recommendations say. So this is the guideline from the Indian scenario from the Ministry of Health and Family Welfare. They do not have any guidelines pre-pregnancy, but they have guidelines once the patient becomes pregnant. And I think from that subgroup, we know that for the first trimester, 2.5 and less is what is a normal thyroid function. For second and third trimester, it's less than 3. So if it is less, no treatment. The treatment is indicated when the levels are between 2.5 to 10 in the first trimester or 3 to 10 in the second and third trimester. So we start 25 microgram of L-thyroxine. In the postpartum period, you should assess this subgroup. And if the thyroid functions return to normal, we should monitor it and stop it if it is coming to normal. But if the levels of more than 10 mAh per liter in any trimester, they recommend a starting dose of 50 microgram and tapering as per the monitoring of TSH. In this subgroup, they do recommend that same dose to be continued in postpartum period. So pregnant women on treatment for hypothyroidism who are already on this treatment, so L-thyroxine dose may be needed to modify according to number 2 and 3, depending on what the values are falling in. Pre-pregnancy doses to be continued in the postpartum period, but this doesn't give answer as a pre-pregnancy time, but it's a good recommendations on how to manage during pregnancy. But again, if we see here, in the first trimester, they said less than 2.5. If we extrapolate this to our population, we know that these patients are, what we need to maintain is a level of 2.5 and less. So I know we are short of time, so I'll just rush through the recommendations. So this is the American Thyroid Association recommendation. So they recommend that TSH concentration of more than 2.5 should be evaluated for thyroid peroxidase status. So Americans are very clear that they should, if it's 2.5 and more, we should do the thyroid peroxidase antibodies. And if antibody is positive and TSH is greater than the pregnancy specific range. If antibody is negative, we should treat when the TSH is greater than 10 milliIU per liters. Therapy considered in antibody positive women with TSH concentration of more than 2.5. And thyroid peroxidase negative women with TSH concentrations greater than pregnancy specific range but below 10 may be considered. Definitely therapy is not recommended for peroxidase negative women with normal TSH, which they take as less than 4 milliIU per liter. Now we have this is a recent publication from 2023 from the American Society. They also indicate that the normal range in our pregnancy is 4.5 to 5. 2.5 is the upper limit of normal, what they say, and subclinical hypothyroidism is defined as 4.5 and more. So it is again a controversy whether we should treat or not, but they do mention that there are studies in this guideline which have shown the evidence that TSH levels more than 4 are associated with miscarriage, but insufficient evidence between 2.5 to 4. So more than 4, thyroid antibody positive, do need a treatment. So, and this is the RCOG scientific impact paper, again on subclinical hypothyroidism and antibodies. So very clear that they defined less than 2.5 to 4 as upper normal limit TSH. They don't define it as subclinical hypothyroidism. More than 4 is mild to moderate subclinical hypothyroidism. And whole of their recommendations are based on that. So we know that just a couple of slides on levothyroxine therapy. Yes, we do treat, but we should not take a message that we should treat everybody, because thyroxine treatment does come with their own side effects. So these are the studies I wanted to say that we should treat our patients cautiously, very, very in a caution way, because they can be associated with side effects. This is the tablet trial looking at thyroid antibodies and levothyroxine treatment. It did show that there was a significant effect on the miscarriage rate and all, but associated with side effects. So we should be monitoring it, we should be treating it rightly, and we should adjust the dose accordingly. And like very rightly, the Indian guidelines said, in the subgroup where it is started in pregnancy or before pregnancy and the levels are less than 10, we should consider revising our doses postpartum. We should not just continue them on thyroxine. So just to take home message, awareness is important. We should know when to treat and when to do the anti-thyroid antibody levels. Yes, early detection and treatment can improve our outcomes. Consult healthcare providers for our patients. It is important that they should not start on their own. They should consult their healthcare providers to kind of a start before they start the medication. Just to summarize, there's a wide variation in clinical practice with respect to testing thyroid function. Serum TSH concentrations above the normal limit, FT4 is SCH, but the UK guidelines do say that it is still, if it is less than 4, it is an upper normal limit of TSH and not a subclinical hypothyroidism. Subclinical hypothyroidism can be associated with developmental outcomes, and hence the Indian guidelines say if the levels are more than 2.5 in early pregnancy, we should start thyroxine because that can be associated with developmental outcomes. And subclinical hyperthyroidism, again, the definition to conclude from these recommendation and guideline is between 4.5 to 5. But again, they also kind of mention that we should consult our labs and look at the reference ranges before we say it is our cutoff. There is a fair evidence that thyroid autoimmunity can be associated with miscarriage, and fair evidence that it is associated with infertility. And hence, if the patient has a history of previous preterm delivery, endometriosis, preeclampsia in the last history, between 2.5 to 4, either low threshold to start the thyroxine or doing thyroid antibody levels. And thank you so much for patient hearing.
Thank you, Dr. Puneet. I think it's a very, am I audible?
Yes, yes.
Yeah, it's a very important topic. And sometimes we also have loggerheads with our, because whenever we are cross-checking with our endocrinologists, then they also always have this doubt that whether actually we need to start a low-dose thyrox for our patients who are planning to conceive or in early pregnancy. So I think the guidelines have summarized it well. And we, whatever the other guidelines say, we have Indian guidelines. So of course, we are supposed to follow them. And what I understand from your talk is because in the first trimester, we are looking at a TSH cutoff of 2.5. So if you get a patient for a pre-pregnancy counseling or infertility, then also it somehow implicates that the target TSH should be 2.5. And because we are supported by guidelines, because sometimes we have seen in clinical practice that if we are actually suggesting a thyroid medication to the patient, they get very, very apprehensive that it's an addicting medication, I'll have to take it for lifetime. So then it is important for us to make them understand that most of the times these medications stop once because we are giving it for subclinical hypothyroidism, and it's important for their quality and for the development of the baby. So I think the talk makes it very clear that our target as infertility specialists should be a level of 2.5. And additionally, doing an anti-TPO antibodies is also important to decide whether we are starting this dosage. Any questions? So there's a question, Dr. Puneet, what do you do in your practice if patient comes in first trimester with TSH 2.5 to 4 with anti-TPO negative? You're mute.
Sorry. So if the patient is pregnant, I think we should start levothyroxine,
Yes.
right?
Yes.
So that is the recommendation
And
from our
25 is the starting dose?
25 is the starting dose, and then accordingly monitoring the TSH and free T4. And it's important that we do the free T4, T3 and not the total T4, T3. This is very important. Yeah.
Yeah. And then once you're starting the medication, checking every 4 weeks.
That's right.
Because we want to know the second trimester levels, the third trimester levels.
Yeah. Yeah.
Dr. Puneet, do you
Yes.
think at what point you will want to send a patient to an endocrinologist? Up to what point you think the regular OBG can handle?
So I think that's a very interesting question, because like if I say that again, Indian guidelines 2.5, because that's what the level they have given as a first trimester cutoff. If you look at the UK guidelines, they say 4.5 is the cutoff what you should treat. And again, with the American, the same 4.5. So I think 2.5 to 4, if it's coming in, and in case, let's say she has a high risk history of being antibody positive, obviously you would do that. But if you do that, and if she's antibody positive and she's got that's what according to Indian scenario is a subclinical between 2.5 to 4, you would take a discussion with the endocrinologist. But if she's only 2.5 and 4 and she's being managed in the routine monitoring, she's managed. So I think then maybe we just kind of talk to them, don't send the patient as such to the endocrinologist.
See, there are certain incidences, no? When
Can I just add something here, Dr. Puneet?
Yeah.
I just wanted to ask regarding this similar question which has been asked. Puneet, suppose this lady has no history of abortion, nothing. She has just got a routine TSH, done it is 2.5. Then do you recommend it again that she has to take alproxin? Because I beg to differ here. So what is your take on this? The similar question which has been asked, like 2.5, she's pregnant for the first time and she has no history of abortion. She is not infertility, nothing as that. And she's having a TSH. Then do you recommend that she should maintain, she should be started on alproxin?
Leave. So TSH of 2.5 with no risk factor, she doesn't need a thyroxine.
Yeah, that's what I wanted to say. Even 2.5, 3, maybe which is even less than the normal cutoff. I don't think so. We should start alproxin. I'm seeing that a lot of people are doing all this. This is not recommended. But if it is on the higher side, then you can get a repeat TSA done after 4 weeks and just think of whether we really have to start. If there's no risk factor, you don't have to decide. You don't have to start alproxin for these patients.
So very true, ma'am. But the only kind of a controversy here arises is that, yes, these are the international recommendations. But that's what we were following. Till this Ministry of Health guideline came from the Indian scenario where they have put 2.5 as a cutoff in the first trimester. So that still raises your question. That if we are making a patient pregnant, we are asking her to enter in the first trimester. So should our cutoff be not less than 2.5? I think that's where
that is where the debate is actually. This guideline is not clear for which they want to make this. Maybe this is for something like infertility, repeated abortions, all those patients who have difficulty, but not a regular any primary patient, because many of the patients will just find they'll be having 3.5 to 2.5, then that is not recommended at all.
So you would recommend a cutoff as 4 as with the international standards, right, ma'am?
Pardon?
You would recommend that above 4 till 4 we should not start.
Yes, something like if it is 5.5, it is some labs have cut off 5.5, some lab have cut off 5, maybe it is 6 or something, maybe then I can get a repeat. There's nothing to worry about, right? Maybe a repeat TSH and then decide. If it is on the rising side, then maybe I'll start.
Ma'am, Renu ma'am, there is a problem here that most of the times patient even, check themselves and then they come, and if something happens in infertility patient,
No,
TSH is 3 or 3.5 and we have not started. In the normal patients also, they would say that Thyronorm should have been started.
No, let me tell you, Nisha, you have to be very confident on yourself. You have to explain the patient. See, your value is this. I don't think you need this thing, alproxin right now. We will repeat it. Patient, I have patients this way. And they're very well, they are convinced about this. It's not that, suppose you have started and suppose the next level comes so low down, then what to do?
So there's a lot of debate on this. We have to be very clear where we have to start and where we don't have to start. For infertility, I do agree
in our
with you.
clinical practice, we just keep our cutoff as 4, to be honest, and then if it is more 4 and more and beyond. But again, we have to see if there's any associated risk factors, high BMI, endometriosis, ovulatory dysfunction. So it can't be just like a generalized statement. We have to individualize the patient and then treat.
Yes, Puneet, I agree with this.
Madam, if the patient is having very high level of antibodies, like running in thousands, so if we have to give any extra medications with the L-thyroxine?
See, sir, for anti-thyroid antibodies, see, if she's having infertility, she has history of abortions, her TSH is normal, but anti-TPO is high. Because you have worked up for that patient because she was having abortions. Then, with anti-TPO high, with history of abortions, then justification.
What medication we can add?
No, ideally, people say L-troxin doesn't work for even if anti-thyroid antibodies are high, L-troxin has no role. This is what, but whatever the guidelines are saying, they are saying that L-troxin can be given.
Okay, I think with the time constraints, I think we can maybe put the questions in the chat box. Dr. Kokila, Dr. Rajapriya, can we just wind up this? Nymphia, are we okay to wind up this session?
Yeah, please.
Excuse me, ma'am. I have one question. Last question, ma'am. Ma'am, nowadays some of the reports also, labs also have started reporting as first trimester and second trimester levels for TSH. In that case, what should we do? They give a separate, normal values for non-pregnancy and for first trimester, second trimester, separate values.
So I think, because they have doing that after these Indian guidelines have come up, right? So I think from that point of view, I think it's better to follow our Indian recommendations. And like I said, the first trimester cutoff is 2.5 and the second trimester is 3 and 10. So I think we should follow that.
Dr. Puneet, can you please summarize it in Dr. Puneet, can you please summarize in 2, 3, 4 sentences because it's a complex,
It is a complex. So just to summarize, I would say that yes, again, 2.5 to 4 is a controversy, right? Still, like I said in the beginning, there are certain medical, areas where we have not reached the consensus. But we should not overtreat because levothyroxine, like I said, can be associated with complications. So till 4, if there is no associated complication, we can observe and monitor those values. If the values are more than 2.5, but there is an associated history of miscarriages, preterm births, eclampsia, and or maybe high antibodies, we should treat her and maybe involve endocrinologists with it. And I think we are very clear, if it is more than 4, we have to treat. So I hope this summarizes this topic.
Yeah, super. Thank you. Thank you, Dr. Puneet. Thank you
so much. So thank you so much for patient hearing. Moving on, I know, apologies for the delay, but we'll be heading on to a very interesting panel, and which I think is very, very important. Like Dr. Abha ma'am said in the beginning, we are trying to have the basics of endocrinology, and the life of a woman starts from puberty and adolescence. That's what we are going to touch today with understanding the menstrual disorders associated with puberty and adolescence. And for this, to moderate this panel, it's my pleasure to invite Dr. Kokila Desai, who is also my co-convener in SIG Reproductive Endocrinology. She has been practicing in Surat as CFS in Morpheus Shivam International IVF Center. She did her graduation and post-graduation from Vadodara. She has taken advanced laparoscopy training and sonography training from Mumbai, Kochi, Pune, and Ahmedabad. She's also had her advanced training in reproductive endocrinology. She received Sulu Rudra Sinha Award in 2008, and she has presented papers and invited as faculty in many different conferences. And at the moment, she's the secretary of Gujarat chapter of IFS. Welcome, Dr. Kokila. It's equally my pleasure to invite Dr. Rajapriya for moderating this panel. She's the managing director of Om Fertility Center, Srinivas Priya Hospital, Perambur. She's a patron of Indian Fertility Society, Tamil Nadu chapter. She's the quiz come South Zone coordinator of IFS. She's the secretary of Women's Wing, Perambura IMA. She's the managing member of OGSSI and Sexual Health Committee member of FOXY. She's also ICOG FOXY regional manager course head in Chennai and she's MRCOG Part 3 examiner. Welcome, Dr. Kokila and Dr. Rajapriya. All over to you to take over this panel.
Thank you, madam. Thank you so much. Dr. Rajapriya, can you invite the panelist?
Yeah, I'll be very happy to invite Dr. Renu Tanwar. She's from Delhi and she's a visiting fellow from Sao Paulo. And she's the director, professor of IVF and Reproductive Biology Center. I invite Dr. Nisha Bhatnagar, and she's pretty popular with the Young Turks as a part of the quiz committee and the Young Turks Journal Club Committee of Indian Fertility Society. So she's the medical director at Avia Fertility Center, and she's also contributed to ICMR research of yoga and pregnancy outcomes. And I invite Dr. Madhupriya, our very own from Tamil Nadu. She's a DNB MRCOG and a budding consultant full of energy from Nova IVF Chennai. I request you, Dr. Kokila ma'am, to invite the other three panelists.
I invite Dr. Piyush Desai. He is practicing as an endocrinologist and diabetologist in a Desai Laboratory Endocrinology Clinic in Surat. He is an honorary endocrinologist of Government Medical College, Surat. He is a member of American Association of Clinical Endocrinologists, also part of Committee of Diabetes, Obesity and Thyroid Network at AACE. Has presented many papers in a various national and international conference. He has conducted many phase 3 and 4 clinical trials and in clinical research in the field of diabetes and endocrinologist. He did postgraduate diploma in endocrinology from the University of South Wales, UK, and he is a recipient of award for excellence in diabetic care by RSSDI in 2019. I welcome Dr. Piyush Desai. Dr. Manisha, she is an all-rounder with achieving an award for that in 1994 in the college days. She's active in sports and good choreographer for a group dance. She's an editor in Alma Mater quarterly news bulletin of SP Medical College, Bikaner, past president of Gujarat State Obstetric and Gynec Society, past president of Surat Obstetric Gynec Society, past chapter secretary of Indian Menopause Society, Gujarat chapter, organizing chairperson of Gujarat State Obstetric and Gynec Conference, organizing secretary of FOXY West Zone Conference and BGDC.com. She's a past editor of Voice of SOGA's Perinatology, BITS, IMS Con, Slovenia. Over and above, she's a very good friend of mine. I welcome Dr. Manisha. Our sixth panelist is Dr. Archana. She's a director of Omega Fertility Center, Sundar Hospital, Teticorin. She's a vice president of Teticorin Obstetric and Gynec Society, awarded ISAR Rising Star Award at TAPCON 2023, member of ISHAR, IFS, FOXY and IAG, speakers at various national and state conference, and conducted many CMEs and workshops and camps in the Teticorin FOXY, conducted awareness programs in many of the fields. So we are starting with our presentation. Sorry. So we are just today conducting a menstrual disorders during puberty and adolescence. I request all the panelists to unmute their mic so that they can answer. The very important is menstrual cycles. In the Indian scenario, the menarche, the average median age of menarche is 13.49 for Indian girls. The range is from 10 to 15 years. Mean cycle interval is 32.2 days in a first gynecological year. Menstrual cycle interval is typically 21 to 45 days in the first gynecological year, and later range is 24 to 38 days. Menstrual flow length is 7 days or less, like 4 to 6 days. And menstrual product which are used is 3 to 6 pads. On an average, we can say 30 ml to 80 ml. So in a puberty age, the menstrual cycles is little bit different from other regular menstruating women's. So now my question is, which type of which menstrual abnormality requires evaluation? Dr. Manisha? Hello.
Yeah. Uh, uh, Actually, if the periods are very heavy, then we need to investigate. If the periods do not begin by the age of 15 years, we need to investigate. If the periods do not begin, in spite of there being a thelarchy since last 3 years or so, then also we need to investigate. If the periods are very irregular, like if we have cycles in 21 less than 21 days, or if the cycles are of more than 45 days, if at any time we have an amenorrhea of 3 months, then also it needs an investigation. And even if somebody says the periods are not very heavy, but still the girl is not able to maintain her hemoglobin, or the her blood count is less continuously, then also probably she's having a heavy period and she needs to be investigated.
Right. So nicely elaborated. So if there is any deviation from the normal menstrual cycle in that age group, then they require to be investigated. Now, how will you evaluate the blood loss of menstrual cycle? Dr. Archana, can you just say us how, like in your practice, how you evaluate that patient is like so many times patient complains that they have a lots of bleeding, they are changing lots of pads, but it is a subjective feeling. So how objectively you evaluate the patient's actual blood loss in their menstrual cycle in your clinical practice?
Actually, in these young girls, the most important thing is from their history. Whenever it affects their quality of life, we do take it as a heavy menstrual bleed. But to take it into the thing, we do have the uh, detailed history when she changes, like as you already mentioned, changing 3 to 6 pads. So when it's more than that, or when she says she passes clots, or sometimes she has checked her hemoglobin and found to be very low, and she has other symptoms of feeling tiredness, easy fatigability, etc. So all those times we can take it. Of course, we do have graphical representation. We have the PBAC scores, scoring, and everything to evaluate the amount of blood loss.
Yeah, nicely said. So nowadays, like it's sometimes we can advise them to give a pictorial chart to put like to tick mark the amount of blood loss. When we are in doubt, we can just give a pictorial chart and ask them to just mark, and we can measure the amount of blood loss from the chart like this. Or hello. Or you can just, and nowadays, like adults and girls are very smart, and most of them are using the menstrual trackers. And there are different menstrual trackers are available in an Apple phone as well as in Android phones. So, and many of girls are using that, and you can just evaluate, or you can just ask them to show that menstrual what they have tracked. And from that also we can about to like able to measure the whether the loss is higher than normal or it's normal. Coming to the case.
Can
So
I
it's a
add something, Kokila, here regarding the
Yes,
menstrual
yes.
evaluation?
Yes, Dr.
Kokila, I
Prachiya,
think so in
please.
the history for the PGs and everything, this is very important ki what they ask. The number of pad is one thing, the clot is
Yes.
another, but the pad, the soakage of the pad is because
Yeah,
some
so
may be
that is
feeling
for the
very
pictorial
hygienic
chart.
and maybe just using 6 pads a day and just removing like that. So that history, is she soaking the central part? Is the whole of the pad soaked? I think that some minor things have to be added in the history.
Yes.
Sometimes we can
You
even
rightly
weigh the
say.
pads. We can even
Yeah.
weigh the pads. Then we will know.
Yes. Anything anyone wants to add? Any panelists want to add in that?
Actually, these days, menstrual cups are also slowly coming in, ma'am, for these adolescents.
Yes, very good.
Yeah.
So we also
Yes.
have to find out what is it they are using and thereby assess the blood loss.
Yes. So assessing the blood loss, and if we found that it's a more than 80 ml, then that patient definitely requires the evaluation. Coming to the case, it's a 15-year-old female with high school student, active in a sports, generally healthy. Chief complaint of heavy menstrual bleeding and irregular menstrual cycle for the past 6 months. Now, she achieved her at the age of 30. Post-menarche history was regular, occurring every 28 to 30 days, 5 to 7 days of cycles and moderate flow. For the past 6 months, her period has become increasingly irregular, is occurring every 2 weeks or maybe delayed up to for 2 months. heavy menstrual bleeding, soaking through pads every 1 and 2 hours for the first 3 days of her periods, and complain of fatigue, lightheadedness, occasional dizziness, especially during her periods. Now, what next do you like to know? Anything more about this patient, Dr. Renu?
So since she's 15 years old and you said she's playing sports also and she's 15 years old, I think so
Yes.
the initial years of the just after menarche, the period seems to be irregular actually. It may take around 3 to 4 years to set for the hypothalamic pituitary axis. And maybe she may be having like after coming after 3 months and then heavy flow and all that. And if she's into sports, maybe the exercise and all that could also be one of the reasons for her. And even thyroid should be checked in these kind of girls. And yes, if they are sexually active, that should also be asked, and whether any coital history or all that can be asked, whether if she's pregnant, and because young girls have started all that now. So maybe all that has to be asked in the history.
Yes, so she has a past medical history, no significant past medical history, no known allergy. In family history, mother had menorrhagia and was diagnosed with uterine fibroid, no family history of bleeding disorders. Non-smoker, non-alcoholic, no drug use, active in a high school is, I say, gymnastic and tracking teams. Diet is balanced, but report occasionally skipped. On
We got the history of, acne, hirsutism, suggesting towards adolescent
very
PCOS.
nice, very good.
That
Yeah,
is,
just to rule out
that
the
is something we
PCOS.
would like to know. Then another
Yes.
thing, maybe some kind of new diet. Nowadays, adolescents are trying different combinations, keto diet, or some exams coming, some shifting taking place in the house, or some kind of stress in the family. Like, some family member is diseased or not well. All these things affect these adolescents a lot. So more specific PCOS, which is very common nowadays, and the other things we can take history from.
Nice. So, detailed history has been taken. A review of systemic examination, general fatigue, cardiovascular, no chest pain, respiratory system, no breathing or coughing disorder, GI, gastrointestinal was normal, except the mild abdominal cramp, and genitourinary tract, heavy menstrual bleeding, irregular cycles. Physical examination were normal. And cardiovascular system normal, heart sounds, no murmur, respiratory was clear, abdominal, no tenderness, no palpable mass. Her pelvic examination was deferred due to like she was 15-year-old, and so the PSPV was not done in that case. So now, doctor, what are the cause of AUB in adolescents you think of?
Adolescent AUB can actually be divided into two types. One could be structural lesions, which are leading to AUB. The other one could be non-structural. Considering the structural, it could be anything like a polyp, an endometrial polyp, a kind of adenomyosis, kind of fibroids, which are involving the cavity specifically. And it could be because of endometrial hyperplasia or due to malignant lesions as well, though very uncommon in the adolescent age group. But still, these are the common structural reasons that can happen. Non-structural could be mainly hormonal imbalance, which happens for most of the adolescents leading to AUB, which could be irregular hormones leading to irregular cycles or associated with dysmenorrhea due to the structural lesions as well. Apart from these, endocrinological lesions are very common. Then the coagulopathy in the family or a personal history of a coagulopathy could be one of the reasons why they have AUB. And it could even be nutritional sometimes, that they do not have enough iron stores, that even minimal bleeding actually can put them into the risk of developing nutritional anemia.
Thank you very much. So basically, we have a lots of reasons available to enumerate in AUB in adolescents. But in these patients, what is your differential diagnosis? Dr. Nisha?
Yeah, I would, first of all, I would rule out normal hormonal imbalances, maybe
Yes,
thyroid,
very good.
PCOS. Then I will go into details about their nutritional status, their history of, again, as I mentioned earlier, stress or some family problem or some special diet or something. Then I
Right.
would go for a scan. I would like to do the thyroid levels and hormonal things first. Then I would like to do a trans-abdominal scan to rule out if there is any, fibroid or any lesion, as ma'am suggested already. One of the important reasons we are suspecting nowadays is pregnancy and, miscarriages. because they are adolescents are sometimes sexually active. They don't even know they take pills, irregular hormonal pills, taking pills, eye pills, popping eye pills irregularly. That is also another thing which we are seeing nowadays. Then the bleeding disorders comes, we diagnose for BT, CT, PT, APTT, INR. So any blood coagulation disorders are there, like we would like to do that. I would advise them to go for lifestyle modifications if all other things are normal.
Very nice. So basically in these patients, like we can say, as Dr. Said is a ovulatory disorder, it can be bleeding disorder, it can be PCOS, it can be thyroid or structural abnormality, or it can be a pregnancy complications. So we require some investigation to be done. So which laboratory test would you like to prescribe, Dr. Madhupriya?
Basically, I would like to know in this patient about the hemoglobin. A complete blood count is very important to know if she has any nutritional disorders, anything like iron deficiency, anything like vitamin B12 deficiency, because she's in the acute phase of bleeding and she's having all the symptoms of nutritional problem. Secondly, I would also like to know if there is any other backup endocrinological problem, as we have already discussed. If there is anything like a hyperandrogenism that is associated in case her BMI was on the higher side and she has a polycystic ovary, if it is because of the hormones, the E2, the estradiol progesterone variation, or because of the hypothyroidism, or because of an associated hyperandrogenism or hyperprolactinemia, which can all lead to the AUB. And apart from this, a transabdominal ultrasound would help to rule out any abnormality in the pelvis. A pelvic mass could be ruled out.
Correctly said. So laboratory test showing the hemoglobin is less. Her coagulation profile platelet is normal, so ruling out the bleeding disorders. Her thyroid functions are normal, ruling out the endocrino problems. Her iron is less, which shows anemia. And further evaluation by sonography was done and there was no abnormality detected. So how will you manage this patient, Dr. Manisha?
Probably she is having hormonal disturbance because of
Yes.
premature
Most likely reason is a hormonal disturbance. Yes.
premature hypothalamo-pituitary axis. So if acceptable, we'll give her oral contraceptive pills for 3 to 6 cycles and lifestyle modifications like active life, some carbohydrate restriction, and she should be very regular with hormones. If suppose she is not willing to take oral contraceptive pills because they are to be taken for 21 days, then minimum 12 days of progesterone can be offered to such patients. And iron therapy along with all this, because the hemoglobin is also less, and diet to improve hemoglobin. Iron rich diet, protein rich diet to improve the hemoglobin.
Right. So as Manisha has mentioned, it can be a breakthrough bleeding. So Dr. Nisha, can you just elaborate what do you mean by breakthrough bleeding?
So what happens is when there is a continuous exposure to estrogen, but there is no ovulation happening, there is an anovulatory cycle, there is no progesterone, it happens as a breakthrough bleeding. Because of excessive estrogen, at some point the endometrium breaks out and we call it a breakthrough bleeding. So usually the reason for this is absence of progesterone, and it is very well managed with supplementing with progesterone. So we would like such patient, if the cause is anovulatory amenorrhagia, then we would like to give progesterone supplementation from day 17 to 21. That leads to regularization of the cycles, and the long-term effects of high estrogen, unopposed estrogen, are also not seen in these females.
Right. So if it's a case of breakthrough bleeding, there are many strategies are available to treat. So I want all the 5 panelists to give what they actually do in their clinical day-to-day practice. One by one, can you just say, Dr. Manisha, you can start with. I think you already said that EOC pills and progesterone. The second panel, like what you do in your day-to-day practice, which hormones you prefer?
Yeah, I
to
prefer
treat such patients?
progesterone.
I'll begin the first cycle with a high estrogen hormone, which is overall G, which has 50 micrograms of ethinyl estradiol. And then because the chances of breakthrough bleeding are less with higher estrogen, then after 1 or 2 cycles, we can come down to 30 micrograms and then we can come down to the low dose oral contraceptive pills with 20 micrograms of estrogen. This is, I usually prefer this way. Personally, I don't prefer giving 12 days of progesterone because girls are very irregular at taking it, and usually the cycles are missed and a chaos is there.
Yeah, Dr. Nisha, what you do? I don't want what book says. I just want practically what you do in your practice.
I prefer giving progesterone.
Just share that.
Yeah, I prefer giving progesterone because that's like a safe choice. And with OC pills also, they have other problems and all. If it is because of PCOS or something, then I prefer OC pills. Giving something like ciprofloxacin or Diane 35 I would prefer that. But if it is just simple anovulatory adolescent cycles, which she has no other symptoms, no acne, no hirsutism or something, then I would prefer to give progesterone, give supplementation of progesterone for 12 days. I usually do not do any implants or IUDs or anything. I simply stick to either OC pills or OC pills because they're even for long time. Sometimes they don't take it for a routine this thing. There was a very efficient device earlier, but this was called Nova Ring. It was a vaginal ring which used to be,
Yes.
So that was also a very good choice.
Dr. Renu, what you do in your day-to-day practice quickly?
Doctor, you're talking about the adolescent, no?
Adolescent with breakthrough bleeding, irregular
Yeah.
cycles in early age, and most likely anovulatory disorders.
Yeah. So for the adolescency, I just tell her to maintain a menstrual calendar. I will tell her that this period will come up after 2 to 3 months. Don't get hassled. If she has heavy bleeding in the withdrawal bleed, if she's not taking any withdrawal bleed, but she has heavy bleeding at that time, then she has to take some Texid tablet, maybe 500 milligram. And if the bleeding doesn't stop in 2 to 3 days, then she has come to report to us. Maybe I will start progesterone for her, but no OC pills. I usually don't give OC pills to these patients. So this is what it is, and then it becomes all right maybe for 1 month. If it is heavy and she's not stopping the bleeding, then progesterones I give them.
Yeah. Anyone else want to add in this? Rajapriya,
I would like to add that for the adolescent age.
Okay.
Dr. Madhupriya, yeah, continue.
Yeah, if the adolescent, according to the BMI of the adolescents, I go, because if they are on the higher side already, and to avoid the high dose estrogen, I like to give only very, very minimal amount of estrogen to combat that withdrawal bleeding for a period of, and then supplement them with the estrogen and progesterone for that cycle, and tell them to continue using very low dose estrogen along with the newer generation progestogens like the drospirenone, to make sure that it helps to reduce their weight as well. Continuing that oral contraceptive pills for the next 3 to 6 cycles will help them actually lose the weight as well. And I would say that lifestyle modification is being helped by this medicine. One, it helps in regularization. Second, it helps in reducing weight in case she's going to shed some weight with the exercise as well as with the medicines and with the diet as well. So I would counsel the patient detail along with her family and then start off only with the very low dose estrogen contraceptive pill with drospirenone after supplementing for 4 to 5 days of estrogen for intermittent bleeding.
Right. So to summarize this, it's a low dose OC pills.
I would like to
yes. Yes, yeah.
Yeah, I would like to prefer contraceptive pills because adolescents have a very high chance of having some bleeding disorder, and estrogen helps in making the clotting factors, and it helps to improve the bleeding. Because this particular case, we were discussing anemia also, so I don't want to take any chances with heavy bleeding. So if somebody is bleeding heavily, the treatment of choice should be oral contraceptive pill, and the traditional ones, the levonorgestrel and ethinyl estradiol combination. And with few cycles, we don't see a much difference in the weight gain with levonorgestrel or the Drospy. The Drospy, for very long cycles, when we give it for more than 6 months or 8 months or 12 months, then there is a difference in the weight gain. But for short cycles and in patients where hemoglobin is low and she is bleeding already heavily, and because they may not show any, because we don't go for von Willebrand factor or any other clotting factors very frequently. We don't go for those details, ristocytine cofactor or something. but high chances are somebody is having menorrhagia from the first cycle, from the menarche, the chances of bleeding disorders are high. So in such cases, estrogen should
We have ruled out, right? We have ruled out, and if regular bleeding due to the ovulatory disorders, low dose OC pills is better to give them for at least 3 to 4 cycles, and then there should be given a break of 3 to 4 months, and we should see whether the hypothalamic pituitary axis has been established properly or not. If not, and if again she come back with the bleeding, then again you can give for 3 months. That is the ideal. And if the patient has associated PCOD or hirsutism, then cyproterone containing OC pills can be given. So the basically ISRA guideline says combined oral contraceptive pill containing low dose estrogen is a preferred and first choice of first line of medicines for patients. So now, if a common bleeding disorders in adolescents has been found, so which are the common bleeding disorders can be seen? As Manisha said, she may be suffering from bleeding disorders. So which are the common bleeding disorders has been found in the adolescents?
Von Willebrand's is common, which we see. Those are clotting factor deficiencies. To suspect disorders, we can have some history in detail, like whether she had heavy bleeding when she had or if we see, we can see for ecchymosis or some bruising from the if she has any small injuries and she bruises very frequently. If she has such kind of history, then the index of suspicion would be very high. Otherwise, also, all the adolescents who have menorrhagia from the initial cycles of menarche, they are very highly suspicious of coagulation disorders, and certain minor coagulopathies are not even diagnosed by whatever tests we know as of now.
Rightly said. So there are various von Willebrand disease, type 1, type 2, type 3. There are thrombocytopenic purpura and then clotting factor deficiency. So these are the different bleeding disorders which may be present, which have to be ruled out. Now, what are the recommendations when you are treating a patients with bleeding disorders? The American Dr. Archana, can you just tell us?
Yes, ma'am. So
when you're treating a bleeding disorder patients, how you tackle with them?
When we generally when we have diagnosed a bleeding disorder, it's better to get the help of a physician or a hematologist with us, and we do correct the anemia, and then the further treatment is according to our diagnosis. So if it is a von Willebrand's disease, generally you have hormonal and non-hormonal. For the non-hormonal, it's best to avoid NSAIDs in this group of patients. So we do prefer tranexamic acid, and of course there is the drug of choice, which is desmopressin, which is available and you can use it. In the hormonal, still we can go ahead with, if the bleeding is not controlled, we can go ahead with low dose OCPs.
Right. So basically, when you're treating with a bleeding disorder, it's very important to find out whether the patients, you should always work with a hematologists and physicians. And the second thing is, whatever medical line of treatment you have decided, you have to see that if there is any contraindication for using that drug is there or not, especially using the estrogen. There are certain patients who are having a contraindication to use estrogen, like patient having cardiac disorders or patient having any other abnormality like liver disorders. All these patients should be kept in mind, and accordingly you should choose the drug of choice. Move to the next. If the patient come with acute episode of bleeding with a severe anemia, what do you do in your day-to-day practice? Dr. Madhupriya and Dr. Renu, one by one.
Okay, so if the patient actually, an adolescent has come with acute bleeding, my idea of choice would be to hospitalize her and completely evaluate to understand what the reason of the bleeding would be, and then to stabilize the patient first before going ahead with the treatment of appropriate cause. This would be obviously every breathing circulation depending on what status that she had come in, if she has come in a state of shock, or if there is no shock but there was only an acute bleeding and she has been compensated already. And this would also go up to a requirement of blood transfusion if necessary. And then, yes, going ahead with the treatment as per the cause. If there's been any hemorrhagic disorders, then that needs to be tackled. If it is, if
wrong.
I'm sorry. Can I continue?
Yes, please.
Okay, and in case there has been an acute bleeding, the emergency could be to stop it with antifibrinolytics like the tranexamic acid or ethamsulate and stop the acute bleeding from happening, and then looking into the cause and treating the cause as such. And this would also involve hormonal therapy, especially the combined oral contraceptive pills at a higher dosage if necessary, and may need up to blood transfusion depending upon the amount of blood that she has lost and the compensated state of shock if she is in.
So Kokila, same here. I would also like admit the patient depending how much pallor she's having, amount of bleeding she's having. Send her all routine investigation. Can you hear me?
Yes, ma'am, we
Is there
can.
anything wrong with
Something wrong? Is it all right now?
Yes, now it's fine.
So even depending whether, so all that general condition of the patient can be take care. I will be starting her tablet texted depending if she's bleeding heavily, even injection texted can be given. Along with that progesterone, if she's bleeding and anemic, I will start progesterone for that patient, maybe 10 milligram TDS and then maybe given for 5 days and then continue for another 20 days. Or so. So this is how I will manage and send the routine investigations of CBC, platelet and all that has to be same.
Ma'am, at what point would you decide to go for either platelet transfusion or BT or iron therapy?
For platelet transfusion?
No, I mean, what point would you decide to go for blood transfusion or for iron infusion or something?
See, if the patient's hemoglobin is less than 7, definitely I would give her a blood transfusion and send all investigations. Anything less than 7 or 7 also, I will give her blood transfusion and stop the bleeding simultaneously with starting the progesterones for the patient and giving Texid along with that. And send thyroid and all other tests to see whether which category she's falling, whether because of hypothyroidism or other causes she's having. So all the routine tests, which we usually do, and then maybe starting the blood at that level.
Yes. So if it's acute bleeding, and if the patient has no contraindications like migraine, hypertension disorder, deep vein thrombosis, or patients having a congenital cardiac anomaly or increased risk of blood clots, in that conditions, you should avoid estrogen. Otherwise, you just give estrogen high dose initially, and then it is to be continued with the OC pills and followed by the regular follow-up to be done after 4 to 6 weeks. And hematological support should be given. Treating the anemia is very important, and if bleeding and depending upon the reports of the laboratory reports, supplements should be added, and they should be managed along with the hematologist, keeping side by side. To summarize this was a study done to find out the what are the menstrual irregularity found in college students, and the study has concluded that more than around 1/3 of the college students suffer from the irregularity in this early age group, being less than 20 years old and having history of early menarche, being overweight and perceived stress were variables significantly associated with menstrual irregularity. To control menstrual irregularity, girls should control their weight, lead healthy lifestyle, include get sleep, which could be aided to training time. So to summarize, we could say all these girls should be advised for a better nutrition, like healthy lifestyle. Sleep pattern also should not get disturbed because it affects the hormonal regulations. And they should be advised to go for regular exercise. And if required, the tablet like ocipil low dose should be added. Now, just I'm handing over to another case, Dr. Rajpriya.
Yes, ma'am, you can stop screen sharing, then I can. Am I able to see the screen?
Yes,
so,
we can.
Not yet.
So, good evening. I know it's getting pretty late, so we'll quickly go through the second
Rajapriya, your
case.
screen is not there still.
My screen is not.
No.
No.
Yes, it's visible.
Yeah, it's visible now. Okay.
Yes,
Yes,
yes.
Fine.
yes.
Fine. Sorry. So it's getting pretty late. So we'll kind of rush through the second case. This case is about the other component of menstrual disorders in adolescent age. This is a 19-year-old girl. She's attained her menarche around 11 years of age. And she has mostly irregular cycles happening once in 3 months for the last 2 years. And recently her cycles are induced only with some medicine. That is her history. She's pretty obese and her weight is around 90 kg. Now, how would you go about the diagnosis? I would just like to request how your opinion will be with respect to the Rotterdam criteria. Dr. Renu Tanwar, how would you like to apply the Rotterdam criteria with respect to diagnosis in this particular girl?
Yeah, Rajapriya, she's overweight.
Yeah.
She's having she's having irregular cycles, which are coming once in every month, 3 months. And even she has to take the periods are at times she has to take a withdrawal bleed as well.
Yes.
So she definitely is there in that group, though there's no comment regarding hirsutism and all that.
Okay. So, but you would look out for that. That's what I mean to say. So clinically, would you start looking out for other signs to get
Yeah,
the
I would like to
diagnosis?
see whether there's any features of hirsutism, the acne, all that will be any acanthosis, nigrans that can be seen. And then the blood lab test, maybe she's diabetic, she could be, the lipid profile is very important in this patient, the blood sugars, fasting PP, would be required. Thyroid, I would like to get done because irregular cycles would be because of that. The serum prolactin also I would like to get for this patient. And if hirsute is there, maybe serum testosterone and 17-hydroxyprogesterone. Maybe these kind of tests I would like to go for the patient.
Dr. Nisha Bhatnagar?
Yes.
Now, we do see a lot of young girls who are less than 18, 19 years of age, where the ultrasound says polycystic ovaries. Already branded ahead of time that they have polycystic ovaries. Your comment on that?
I think ultrasound is not the right criteria to diagnose PCOS because these are young patients. Their ovaries are, they're full of potential follicles. So there could be a multicystic ovary, not polycystic. I think it should be diagnosed only with the clinical symptoms more, the history of and menstrual irregularities or hirsutism or obesity, or like you added like taking something for having periods like withdrawal bleeding only. These are the important points.
So I think it's most important for us to convey the message that to strictly depend on history taking and a proper clinical examination and then order some relevant tests, not brand the individual as polycystic ovaries just by looking at an ultrasound report. And we do understand adolescence is a phase where the girl really wants to look beautiful, have clear skin, good hair. And unfortunately, they will be challenged with hair fall and hair growing in the wrong places. So how many of you, Dr. Madhupriya, do you do a standard Ferriman-Gallwey scoring when you examine an adolescent PCOS patient?
Ma'am, I don't think in a busy setting it is possible to do a complete Ferriman-Gallwey scoring. I go ahead scoring, which actually the external appearance, if she has a beard, the mustache, and the chest or the abdomen or any acanthosis nigricans, then these all will culminate and tell us that it's going to be on the higher side, which is equivalent to that of a detailed Ferriman-Gallwey of more than 8.
Absolutely agree. That's practically what is going to happen is what I want you to say, right? And Dr. Archana, at 19 years of age, right now, this girl...
Rajapriya, can I add something, please?
Yeah, please, ma'am. Yeah. Please.
So the thing here is that we also need to take history of taking treatment. Like most of them are taking cosmetic treatment. They are using some kind of, hair laser therapy or something. So we don't know exactly that what is going on. So it is important while assessing these patients to take that history as well.
Absolutely agree, ma'am. That's a very good point made. Today, at the age of 12 and 13, they visit cosmetologists and get a full body laser done, including the pubic area. So that's a point well taken. It is better to look into the cosmetic history as well. Dr. Archana, This particular young girl who's 19 years old, the recent 2 years only, her cycles has been very chaotic. And I think the international consensus is very clearly telling that even if previous cycles were regular, we look more in towards the recent cycle. How far do you do a testosterone level when you get a PCOS suspected patient? Is it part of your routine practice? Dr. Archana Ambujam?
Yes, ma'am. Yes, ma'am. Going for testosterone, when I do suspect PCOS by the clinical and clinical features, and I see the hirsutism and all, I do go for it, ma'am. When I see fine signs of hyperandrogenism, to confirm it, I do go for testosterone estimation.
So, do you have a particular cutoff level, or you look at what your lab standards are giving? Would you like to do the total testosterone, the free
Yes, ma'am.
testosterone?
The free testosterone and in some cases the free androgen index I look at, ma'am.
Okay. So you would probably look at the free androgen index if there is more gross features of virilism, and you probably decide you have to suggest some therapy for them, you might do it. Now, very clearly, PCOD in teens is like a mimic picture of PCOD. If you do an ultrasound, as we rightly said, multicystic ovarian appearance is there. And the ovaries are generally of larger volume because of the adolescent age, and a trans-abdominal ultrasound may not be accurate. And anovulatory cycles is almost 40% in the immediate years following menarche. This we already had Dr. Kokila talking about. And we really need to understand that high BMI is pretty common again in teenage, because if you get a BMI of less than 24 is becoming more of a rarity these days. And clearly ultrasound a strict no-no, because the PCOS morphology is seen as high as 40% within 2 years after menarche. And the international guidelines say wait 8 years post-menarche before you resort to ultrasound for diagnosis or make PCOS as a label.
Yeah,
So
just
when we are doing, yes, ma'am?
Just Rashtriya, can I add? The Israeli guideline says the sonographic diagnosis of PCO should not be done till
Yes.
8th gynecological year.
Yes, ma'am.
They said 8. So from the menarche till 8 years, sonographic diagnosis of
Yes.
PCO is not right.
Absolutely agreed. And at least, Dr. Manisha?
Yeah.
Dr. Manisha, do you make it a habit to teach a young girl to maintain her menstrual cycle chart and how to go about it, and thereby try and understand that even more than a year post-menarche, you should start suspecting that they are getting PCO programmed. You may not label them, but you need to catch them young. So
Yeah.
would you go by this particular post-menarche pattern more than 1 year itself if they hardly have 6 to 8 cycles per year? How would you go about this particular comment?
I usually call the mother also along with the girl, because nowadays we see menarche is at 11 years.
Yeah.
So the girl is slightly young to maintain, and many a times mothers don't discuss. So I call them both of them, and together I explain that you should maintain a menstrual calendar, and this is going to be regular. That your first up to 3 years of menarche, you may not have regular periods, and that's normal. But because of the high fast food generation, we see obesity is becoming very common nowadays, because I think the average weight of adolescents is now 50 kilograms, which used to be 40 kilograms in our generation. So this extra 10 is all because of the fast food and everything. So because if we correlate it with exercise or some game, or because girls are very fond of dances, I usually ask them to join some dance class or something, because that activity the girls love. So even the mother will accept, because now the doctor has said so, make them active. And I ask them to maintain a menstrual calendar along with the mother, and explain how the amount of flow also, so that we come to know what she's, because it is very difficult that to accept that the girl is understanding everything very nicely at her first period. So lifestyle modifications along with what should be monitored is explained, and if some perversion occurs, then they have to come. Or if she feels weak, if suppose she doesn't feel like going for dance or doesn't feel like going for walk or exercise.
Ma'am, we'll come back to that later, ma'am, because we are trying to rush up a bit. I'm really sorry. I understand lifestyle modification, something we have to make sure it happens rather than just putting it in one word. Dr. Piyush?
Dr. Piyush is not there. I
Oh,
think
she's not there. Fine. Then I would request Dr. Renu to take this question. Now we clearly understand we are dealing with a PCOS patient and she wants regular cycles. That's the reason why she's sitting in front of you in the clinic. Her ultrasound is showing large volume ovaries at 19 years of age and her lab parameters are showing testosterone level is high. She's already got a high fasting blood sugar, 140, evidence of dyslipidemia. Her blood pressure is also slightly on the higher side and BMI is almost 34. Within this situation, yes, we had Madam Manisham Madam talking about positive lifestyle modification involving the family into helping the child and programming exercise which the child will enjoy and give small increments of weight loss, not big demands of losing weight. Now, once they want regular cycles, Renu ma'am, what would your choice be? Would it be oral contraceptive pills for regularizing periods, or would you offer progesterone withdrawal on a regular basis? What would you prefer?
Rajapriya, usually for these PCO patients, adolescents, I usually give them a progesterone withdrawal bleed. I tell them that they have to take after every 2 to 3 months to have a withdrawal bleed. They cannot be amenorrheic for 6 months or 5 months. This is what I usually do. And tell them a lot of weight loss. They have to keep a weighing machine with them in the bathroom. They have to see that in 1 month, they have a target of at least reduce 2 kgs per month, not a big target, but and then whites, breads and all that kind of white reduce weight. Regarding this patient, since diabetic or metformin has to be considered for this patient because of diabetes as well as for weight loss, and even that androgenic levels can also come. So this patient will require metformin as well.
So what would be your preference of contraceptive pill combination?
Yeah, if the OC pills can be given to this patient, but anti-androgenic would be better for this patient because she's hirsute as well. But since estrogen is also there, low dose estrogen with anti-androgens.
Fine, ma'am. Now, Madhupriya. Madhupriya.
Yes, ma'am.
Yeah, see now, first line treatment is because she's very particular that she wants regular cycles and she's having only induced period. Ma'am was just saying we could use for 3 months period and then shift her over to withdrawal with progesterones. Right now, if you find the testosterone levels high, what is your preferred preparation of bringing in a lowered testosterone level as well as to get regular periods?
Obviously, a low-dose estrogen level combined with the anti-androgens to combat the hirsutism. Any anti-androgenism which contains cyproterone acetate, a group of progesterone like cyproterone acetate would be helpful in such cases.
See, because we do have quite a choice, no? We have combinations with drospirenone, with desogestrel.
Yes.
Even today we have with dinogest also. So how would you choose who would go with what?
Obesity, if there is going to be an increase in the BMI, such as in this patient where it is more than 30, then definitely...
Metabolic syndrome. If you find a metabolic syndrome type of PCOS.
Yes. Yes, in those patients, yes, drospirenone is going to be helpful as a combination with the low-dose estrogen. And in case of people with hirsutism, yes, a combination of the low-dose estrogen together with the anti-androgens would be helpful.
Right. So it is important for us to make a choice when so much of choice is there based on sometimes the profile of the PCOS, the phenotype, the metabolic features, as well as how they're able to cope up with the side effects of the preparation you're using. Now, sometimes the patient will just say, I had so much of giddiness, so much of nausea. She would take it just for 5 days and then she would stop. Again, she will come back to you with spotting. So it is important for us to find out that particular combination which suits. And we also had Renu ma'am saying it's really important to use metformin. Dr. Manisha, how long would you put her on metformin if you decided it is going to be metformin?
Initially for 3 months, I think, depending upon how well she's taking the lifestyle.
Yeah, because her fasting blood sugar is around 140.
Yeah. So, we'll see with the lifestyle modifications and metformin together initially. And then we'll reassess if the things have improved. If she has already lost some weight, then probably we may not need metformin later on.
Right.
It actually loses.
Okay, so this is one of the important situations where we use metformin. Otherwise, guidelines clearly say without an indication, we cannot use metformin regularly. And particularly a specialist. Yes, sorry.
Yeah. I think these inositols can also be added in these patients. In my practical practice, I add inositols with this as a hypoglycemic agent for these patients, especially adolescent PCOS.
Right. When glucose tolerance test is normal.
Kokil, lot of debate. There's still
Yes.
long research to be done on
Yeah.
inositols.
Yeah, that's
Okay.
why I put in the
Now
word
we have
it is
stopped using that.
controversial.
Yeah.
And probably it is the
Is
practicing
because of
consultant's
side
opinion.
effects?
It's based on favor, right, ma'am?
Okay.
So metformin is particularly useful when the BMI is high and the GTT is abnormal, and it works in many ways. However, again, for young girls, the gastrointestinal symptoms and the side effects lead to a discontinuation in a good lot of young girls. And the usage is it suppresses appetite, and we can probably tell them by using it properly, they have some amount of weight loss. And Dr. Archana Ambujam, up to how much of dosage would you go? How would you plan your dosage of metformin if you are initiating because of the high blood sugar?
Actually, this drug is quite difficult to tolerate, particularly in this age group when they are really when they are adolescents. So I'll start with a minimum dose of 500 milligrams, probably at bedtime, and gradually increase it with 500 milligrams per week, going up to a maximum of 1,500 to 2,000 milligrams.
So how often would you call them back to see it's working? Like, so I really don't know whether in theory they will be able to handle,
So
right?
we
Most
have to
of us,
monitor her sugars. I think 4 week, monthly once, we will recheck her sugars.
and practically speaking, I think most of us go up to 500 mg twice a day and try to play safe, right? But insisting
There is
more on
a
lifestyle
Dr.
modifications.
Rajapriya, Dr.
Yes.
Rajapriya.
Sometimes with when they're really obese, they require up to 1.5 grams.
Yes, Dr. Nisha?
Dr. Rajapriya, there is a 1,000 milligrams sustained release tablet.
Yes.
Which
Yes,
is
ma'am. We
very,
prefer the
very
sustained
well
release.
tolerated, which is
Yes.
very well tolerated.
Yes, so that's what I was saying. The extended release form of metformin is much better tolerated rather than the short term. So based on the individual, it is sensible to use the extended release form. And end of the day, the woman doesn't, a lot of these young girls are pretty worried that long term they will have to take medications either for their metabolic symptoms or for their menstrual irregularities. And it is important for us to discuss that polycystic ovaries doesn't have a cure, but it has a fantastic control with good lifestyle modifications. So, Dr. Renu, what kind of a follow-up plan would you put for this girl?
See, definitely I tell them that they have to maintain their weight. They have to maintain their diet. They have to stop getting their whole night. Actually, they are on mobiles and not sleeping. That's very important cause because the cortisol levels also behave that way. That has to be told that the night sleep is very important rather than day sleeping. And then they have to be told that they have to, because this is a long-term disease, may land up metabolic syndrome, the withdrawal bleed has to be taken. Then they have to get married in time. They have to conceive in time. They may have difficulty in conceiving. And then they have to maintain their blood pressure and all the lipid profile, all that has to be checked regularly. And even endometrial CA has to be told to them. If they don't take withdrawal bleeds, maybe the hyperplasia can lead to that. So all that has to be told to the patient.
Dr. Nisha, as part of the follow-up, we tend to do blood sugar, tend to do the lipid profile. Recently, there's a high instance of fatty liver, which is being noticed in adult PCOS patients. So have you brought into practice checking for the liver enzymes?
So, honestly speaking, no, not as of now. That is not part of.
There's rise in the
Yes.
Have you noticed
Yes.
that?
I have noticed that, but till now I have not included that as a part of routine investigation. But I was also thinking that almost every other ultrasound we come up with fatty liver.
Yes.
I think I tell them that you are having liver of someone who's drinking so much. So you have to improve that, otherwise liver cirrhosis.
Ma'am, today if you go to the pub,
when the patient and metformin, we do get LFTs done for these patients.
Yes. Yes, ma'am. And I think alcohol is also there already now, ma'am.
Yes.
Kind of quite a lot of young girls visiting the pubs.
Not only alcohol, other things also. There are too many toxins available too easily.
Yes, ma'am. So I think it is important for us to look at their whole self. And how many of you start them on some treatment when there is elevated triglycerides?
I usually counsel for lifestyle modification. I tell them that you are 20 and you are looking like a 2. So
Yeah.
if that fast you are aging, so then you imagine how your later life is going to be. So I counsel them very well, and I believe that there is a lot of counseling is needed for these people. Maybe
Very true,
psychological
very true.
consultation we can do that
Very
helps
true.
them to get back on their feet.
A consoling factor here is that the hypertriglyceridemia, which happens in
Yes.
the adolescent age group, is usually reversible. Particularly if she is an obese person and the BMI is on the higher side, then reducing weight definitely brings her back. So we need not put her on any anti-cholesterol agents as such.
So I don't
And
start
as
it, but
And as we are trying to correct their menstrual disorder, they become a regular long-term client of ours. So each time we have to reinforce, as all the panelists agreed, that long-term sequelae is there with respect to fatty liver, diabetes, hypertension, infertility, sleep apnea, abnormal bleeding, irregular cycles, and risk of endometrial cancer because of most young girls are pretty happy when they don't get their periods. No? They are menstruation free and they look at it as a positive point of health, but we really have to tell them if they don't get regular menstrual cycles, at least 8 to 9 cycles a year, it is going to be a higher risk of endometrial cancer. And they don't even tell their parents that they hardly have their period. So it's important for us to educate them. And a good lot of them that low self-esteem because of their lack of body positivity leads to depression and anxiety. And as you all said, counseling, and involving a psychologist if need be, right? So I think catch them young should be our theme.
I
And
think
even a small weight loss we have to appreciate. So what do you
Dr.
do?
Rajapriya, instead of catching them young, maybe we should catch the parents before
Yes.
they are like, they become adolescent. So the
Yes,
parents should be educated before even the girls become adolescent.
But Nisha, who is listening now? The young girls don't give a credit to the parents now. They don't listen at
Ma'am, they
all.
are very smart. The girls nowadays are very smart. Most of them have their menstrual calendar. So if we
No, that's
counsel them
okay.
well,
That's
yeah.
okay.
But the developmental theory actually dates back to the organogenesis and the gametogenesis
to catch
period.
the mother.
Yes.
Yes.
That's the
So
potential
catch
mother.
the mother.
Catch the potential mother.
Potential
So
mother.
probably we
She
have to
becomes a
get the
mother.
key word to get that adolescent girl to be sensitized and to listen to us. For some, it may be cosmetic. For some, it may be long term. For some, it may see. We have to probably say, if you're PCOS, you're going to generate a PCOS child. If it's going to be a daughter, maybe catch her somewhere. So thank you so much, panelists. With this, we move to the
Thank you, Rajapriya, and thank you, Kokila, for
no, we are
moderating so
continuing.
well.
Now we are going to get
No, we
rapid
have
fire
rapid
session.
fire
Dr.
questions.
Kokila.
Acha, we are still there?
Dr.
Okay, okay.
Dr.
Yeah.
Archana, Dr.
Yes,
Archana,
ma'am.
this is for you.
Yes, ma'am.
17-year-old girl, history of oligomenorrhea for the past 6 months, previously regular cycle. Additional symptoms are galacturia, occasional dizziness. Family history, not known endocrine disorders. Lab finding, prolactin levels significantly elevated and MRI showing pituitary macroadenoma. What is your diagnosis?
Hyperprolactinemia, probably secondary to the prolactinoma, ma'am. And
Right. Right.
I would like to treat her
So,
with
yeah. So when the patient comes, it's necessary to ask the associated
history
complaint.
suggested. Yes, ma'am.
Yes. Okay. Next. This is a question for Dr. Nisha. 18-year-old girl with history of oligomenorrhea for the past year. Recent stress due to exams. Additional symptoms are weight loss, increased exercise habits, low FSH, low LH in a laboratory finding source, and normal thyroid function test, normal prolactin. What is your spot diagnosis, Dr. Nisha? It's functional hypothalamic amenorrhea. Yeah, right. So many times patient comes in a stress, and we have to keep this in a mind, and just giving a OC pills will resolve this, balance the hypothalamic pituitary ovarian axis. The last question is Dr. Madhupriya. 14-year-old girl, Manak at 12 years, now experiencing heavy and prolonged menstrual bleeding. Additional symptoms are easy bruising, frequent nosebleeds. Family history, mother had heavy periods. Lab finding, normal coagulation profile, normal prolactin, normal thyroid function test. What's your diagnosis?
Could be either a von Willebrand's disease or an idiopathic thrombocytopenic purpura, because usual coagulation disorders will not rule out von Willebrand's disease. So specific von Willebrand factor, if it is negative, then I would think about ITP.
Yes.
So basically, yeah, if you think of ITP, and basically you have to ask them to do the 1 milligram factor and platelet count. If low platelet suggestive of ITP, and if antigen positive, 1 milligram, because the management in both the cases are different. ITP may require short-term steroids.
This question is to Dr. Renu. This is an 18-year-old, very calm-looking girl. She's brought by her panic-struck mother with history of passing profuse clots, abnormal clots, PV, along with tissue-like clots. This is of acute onset for the last few hours. She has had no menstrual complaints so far. What could be the probable cause? Any hormone-related or bleeding thighs related, or is it a possible miscarriage?
Possible miscarriage, Doctor.
Yes, you hit the nail on the head, Renu ma'am. So we have to be ready. She had actually gone to the pharmacy, got over-the-counter Miffy Myso, and her mother caught her in her room bleeding abnormally with the products and tissue coming out. And this is actually a real-time scenario. Now, that's the situation. This is another 15-year-old girl. This question is to Dr. Manisha. This 15-year-old girl has on and off intermittent bleeding the last few weeks, and she's been going and meeting doctors on and off, telling the same problem and getting different prescriptions the last 1 month. What is the important history you need to know to be able to sort out the problem? She's seen enough doctors. You need to be the last doctor handling her. So these are the options: history of irregular cycles. Probably she's missing some pills in a prescription of the previous doctor, or is it a previous history of similar problems and it is happening to her again? What would you think could be the cause, Dr. Manisha?
Intake of this. Doctors.
Exactly. Exactly. A lot of times they will not reveal the history. Up to us to get the history as to who she went to, what is the prescription, because they only say the presentation of the disturbance happening in the background. So sorry about it.
Priyanka needs to be muted. Dr. Priyanka, please mute.
All right, this question is to Dr. Renu. This is an 18-year-old college girl who has attained her menarche 4 years ago with history of mostly regular cycles, and recently she's got a missed period for 3 months. So could it be exam stress, or she's into some weight loss efforts, or could it be pregnancy? And if it's going to be pregnancy,
it could be a weight loss efforts also.
Yes, yes.
I
So
think it could
kind
be
of
all
be
three.
any
It
of
could
this,
be all
right?
three.
Any
There
of
should be a
these,
fourth
yeah.
option, all of the above.
So what's the technique you would use to check if she's pregnant? Because it's a very sensitive thing. She's a very studious girl. So if you're suspecting, at what point would you want to check it out? How would you check it out? Would you order a pregnancy test, a beta HCG, or you would make
No,
her
we do a urine pregnancy test.
Won't she get offended, ma'am?
No, we will tell her that is the first thing to be ruled out. Maybe I'll go for that. I'll explain her, maybe separately, not in front of everybody.
And saying, ma'am, you have insulted me. I'm absolutely not that kind of girl. I refuse to do a pregnancy test. That's a pretty tricky thing, no, ma'am, to be able
I know it is. Then maybe a beta HCG for her. If she doesn't listen for the urine pregnancy test, maybe a blood test, which is maybe to confirm that. Maybe I'll do that.
Actually, my mom is a gynecologist. She would go and do the urine test in the lab, and because it was our own hospital, for urine routine she will write, but if the trick is there, they will do the UPT. So,
but nowadays, Dr. Rajapriya, we see a lot of difference. Earlier, like 10, 15 years back, girls were a little shy. They were a little scared. They were coming for this thing. But now they come openly and they said, I had intercourse. Now pregnancy test is positive.
Ma'am, they come with their UPT test positive.
No, Dr. Rajapriya, now I've started asking this question, are you sexually active? And they say, yes, I'm asking this openly now.
With confidence.
And they admit and they feel very proud about it. So that's the story now.
So yeah, I absolutely agreed. Like we've seen a great change, and it is good that our adolescents are coming forward. Asking for help. So we should not be judgmental about it. She's 18, 19.
Yeah, definitely.
We have to help them out when they need our help.
Yes.
So but thank you so much.
One thing, I just want to add one thing. At this particular point, when they are coming with a positive pregnancy test, I think this is the best time to counsel them for contraception.
Contraception.
That we should not lose. We should
Yes.
tell them that repeated abortion is not good for you. You are
Yes.
suffering. So we should advise them contraception at this particular time.
Agreed, ma'am. Agreed. So thank you so much, Puneet, ma'am. Is
Thank you
Pankaj
very
sir
much,
joining
Dr.
us?
Nisha, Dr. Madhupriya, Dr. Renu, Dr. Manisha, Dr. Archana, and my co-moderator, Dr. Rajpriya. And the last wisdom of be there with Dr. Sir. Everyone knows Dr. Pankaj, our president. So any attempt to introduce Dr. Pankaj Talwar would be an understatement. Dr. Pankaj Talwar is a well-rounded professional in ART, admired for his excellence as a teacher, mentor, and clinician. His dedication to his work and society is evident in his exceptional ability across ART. He has trained 1,700 students globally in the ART in the past 3 years across 23 countries. CEO of iHome Fertility Clinic and iSIT Academy, Gurgaon, Delhi. He is a Dean of the Department of Clinical Embryology and Reproductive Medicines at Sridhar University, Pilani. Founder of Global ART Digital Schools. Founder Secretary of Fertility Preservation Society of India. He has awarded Visist Seva Medal, Tapisar Award, Best Research Paper Award, and Best Research Project Awards. Icon of North India 2022-20. Experience of setting up of 29 ART central labs globally, conducted more than 150 live workshops, edited books, more than 100 publications, and he's trained in a human embryonic stem cell derivative at Israel, ovarian cryopreservation from Paris, PGD and TQM from Germany, Spain. So I invite Dr. Pankaj Talwar for the words of wisdom.
So I would just kind of a little speak on his behalf because of the delay in our timings. Unfortunately, he had another meeting lined up. So, but he has sent wishes to everyone. And he would join us for the next webinar. So we have missed him this time because of slight delay in our times. But he has sent regards and wishes. So I think over here we can conclude. Thanks to my co-conveners, Dr. Kokila, Dr. Rajapriya, and all my faculty. I would hand over to Rajapriya to give the final votes of thanks.
Thanks for the opportunity, Puneet, ma'am. I must say a lot of efforts has been put by Dr. Kokila Desai to kind of plan this program. The speakers have been fabulous. We've had our mentor, Dr. Abha Majumdar, who spoke a great insight into AMH, and we've had Dr. Puneet open up a Pandora's box, what is subclinical hypothyroidism. And we've had such enthusiastic panelists who have given a lot of practical input to dealing with menstrual disorders. So thanks to my co-moderator, Dr. Kokila Desai. This program cannot be a success without almost close to 100 delegates who logged in. And obviously when discussion time runs out of hand, and we had so much of discussion, and I think that's most important in a program where opening up to questions, doubts, controversies, and trying to sort it out. So I thank who has given us this online platform to do these programs, and looking forward to Dr. up with more and more interesting packages on reproductive endocrinology discussion. And it's time to say, and a big thanks to each and every one of you. And we're hoping that next time we'll maintain time and get words of wisdom.
Thank you.
Thank
and
you.
the panel questions were excellent. Thank you so much.
Thank you so much.
Thank you. Good night,
everybody.
Thank you.
Thank you.
Madam.
And
Thank you,
apologies for
Rajapriya
the
and
delay.
Kokila, madam.
But thank you so much.
Thank you.
Thank you.
Thank you. Thank you.